मेरे को खाएगा क्या खाएगा कुछ नहीं ये दिमाग जरूर खाएगा आप फोन से बड़ा होगी सीधा पहन यार भूत आ गया तेरे को खा जाएगा ऐसे तो हट जाओ या मीति ये क्या है कैमरा ऑन है तो बना के ये देगी चलो ना ऐसे भी सिलेक्ट कीजिए यूट्यूब का है
Hi, Nilesh.
Sir, can you hear
Can
me?
you hear me, Nilesh?
Yeah, very well.
Yeah. We have a UPS backup or something. Suppose suddenly
Sir,
the
can
power
you?
goes off.
Oh,
Can you hear me?
I need to rush to hospital then.
Why? What
Yeah, I
happened?
need to rush to hospital.
Why?
I don't have a UPS at home, sir.
Yeah, ask someone to get it for you, just to keep you backup. Because suddenly the power goes off, then
I can be in hospital in 2 minutes.
okay, do that.
I'll rush to. I'll
Yeah,
rush to hospital, sir. I'll be in hospital say max 5 minutes.
yeah,
Max takes
fine.
5 minutes.
Okay, no problem.
Okay,
Yeah,
I'll get back in 5 minutes.
yeah,
Just 5 minutes. Okay.
no problem.
Okay. Can you just check YouTube once, sir? YouTube, your
You,
YouTube,
YouTube. How do I go on from here to YouTube?
sir.
Uh,
Go to your
okay.
YouTube channel.
Yeah,
Go to
it's
your
it. Like,
YouTube.
yeah, it's it. Live on YouTube. I'm getting it. I'm going.
Can you see? Can you see me?
I'm just, yeah, I can see you too very well.
Okay, okay. So
Yeah,
just give me
say,
5 minutes. I'll be like this in hospital.
yeah, okay, okay. So you're switching it off, okay? My YouTube, okay. Go to my YouTube channel. Yeah, I'm in YouTube channel. Yeah, yeah. It, no, I'm on YouTube now. Can you see me on YouTube? Yeah, quick, because they'll try to keep on entering. Okay. Hi, Alex.
Hi, Goslar. Can you hear me?
Hello. Hi, Alex.
Goslar, can you hear me?
I can hear you very clear, Alex. So nice to see you.
Yeah, nice to see you.
I can hear you very well. I think you're muted yourself. Kindly check your mute. All well?
Yes, with me, everything is all right.
Perfect.
I don't wear a mask because I'm at my home.
Actually, there's some work happening at home, so I'm going up and down, some carpentry work. So whenever I go to that room, I'm making sure I'm wearing a mask.
Oh, yeah. Okay, okay.
Yeah.
Oh.
So it's just that this mask keeps hanging on my neck all the day. And you?
Yeah. Ja.
Ich erkläre es dir kurz, okay?
Yeah, yeah.
Also wenn du nachher...
My son Konstantin is with
Hello.
me.
Hi, Konstantin. It's nice to see you. It's been ages. I think
I'll just explain to him what he has to do when his
Please.
presentation is on, all right?
Yeah, you can put him on. We can see
Ja,
that way.
Also, aber du musst dann hier
Bildschirm
Bildschirm
freigeben.
freigeben. Nur als Test mal.
Ja, okay.
So gibt's Bildschirm.
Okay, und dann...
So, dann Bildschirm, und dann klickst du jetzt, genau, kannst du auch hier drauf.
Ja, exactly.
Teilen.
So.
Und jetzt wird nur das hier gezeigt, nur das Programm. Jetzt gehst du auf groß.
Aber das soll man, glaube ich, nicht zeigen dann, ne? Oder? Geh mal auf das. So, das ist richtig, ja.
Und jetzt frag ihn mal.
Goslar, is my presentation well to be seen?
Yes, it's quite well seen. You can scroll it so that we can see it's coming up. The slides are coming up or not.
Can you repeat? The connection is
I'm
not so
sorry.
good. Can you repeat it?
Can you scroll the slides so that we can
Yes.
see this? Yeah. Oh, good. So the slides are moving. Fantastic. It's
okay.
working. It's working. Perfect.
Okay, fine.
Perfecto. Perfecto.
Also das musst du nachher drücken. Hier kannst du jetzt.
Yeah. I think I lost one movie when I changed over, but it's only a small one, how to insert a little plate, but it's not decisive. You can
In
do it.
fact, that's the key for me to see your baton plate. That's what we want to introduce it into India.
Yeah. Oh, very good. Are you in Hyderabad now?
I'm very much in Hyderabad now. Presently, I'll be going to Rishikesh in the first week of December.
Mm-hmm.
Now, I go there 4 days a month.
Uh-huh.
Because of the COVID, the hospital has more COVID patients and our department is closed.
Oh,
So we only do emergencies and trauma, nothing more than that. So as of now,
too bad.
Yeah.
And the cleft children can't be treated. Yeah, it's too bad.
Yeah, it's going on. It's a very difficult time for everyone. So the only way to keep the life active is webinars.
Well, right now in Germany, we have that second wave of COVID, which is not really good. And the hospital is filling up much more than in springtime. In springtime, we hardly had any patient. But the people here, some of them, they are COVID skeptics and they don't believe in it. And some say it's just a flu and they don't really wear masks. Consequently, here in Leipzig, it seems to be quite good. So we don't have so many cases, but it worries me. And I do hope that the vaccines really prove to be good. So maybe in the summer or in next autumn, we can start traveling again. And the whole thing will come down.
Yeah, the same. It's exactly the same even in India.
Too bad.
It's very difficult to monitor people to have these COVID protocols. Mm-hmm. So it's, in fact, it has come down in few parts of the country. And then in a few parts of the country, again, like Delhi and all that, it is just shooting up a lot.
Oh, God.
It's yeah. So I think even the other colleagues are just joining in.
Yes.
Yeah. Because
give my best regards to your wife and children.
Sure, I would definitely, and same from my side to Alex. The main gentleman who is organizing this meeting, his name is Nilesh Pagaria. He was one of my former fellow, a good chap.
Very good.
He did his fellowship way back in, I think, in something like in 2009. He established a very good center for himself in the central part of India. And he's going to join. He just went to the hospital because he found that he has no battery connection if the power goes off at home. So he's just gone to the hospital to connect his laptop there. He'll come in, I think. I'm just waiting
Oh,
for
yeah,
him.
yeah.
And the
I
other
mean-
people, participants, yeah, the Rajesh Mane is here.
Well
Even Sharon.
organized as you are, you asked us to start a little bit early.
Yeah, just to make sure that, we all get to see
Yes.
each other and make sure that things work. Yeah. Yeah, Nilesh, are you in already?
I see this gentleman, Nilesh, yeah?
Yeah, you
Pagaria.
see him? Yeah.
Yeah, I see him.
Can you hear me well?
Yeah, Nilesh. So now you should take over and
Good
make sure
evening, everyone. Am I audible enough?
Yeah, Nilesh, I can see you now. Is Sharon in now? I think
Am I
Sharon
audible?
is. Yeah, you're quite audible, Nilesh. Yeah,
Oh,
we can see you well, and
So we're going live on YouTube as well.
good.
Pretty much there. Sir,
So you can ask other colleagues to share the screen to see if the.
Dr. Sharon, can you share your screen once for us to see if it works well with your presentation?
Ah.
Sharon, does it work?
Can you see him on the screen, Nilesh, anywhere? Because
Yeah.
he's logged in.
I can see him very well.
So you can see him. Then but he's unmuted also, so he should be able to talk. Or in the meantime, you can ask Rajesh to do that. Dr. Mane.
Dr. Rajesh? Dr. Rajesh? Oh, there it goes. Yeah.
Very good.
Dr. Rajesh's screen is nice and visible.
Yeah.
Dr. Rajesh,
Can you hear his voice?
Hi there.
Hello,
your voice is nice and clear.
That's Sharon, I think.
I'm
Hi, guys.
Dr. Aditya, Sir's PG.
Oh.
Dr. Rajesh Mani's PG.
Oh, okay. So
Yes, Dr. Rajesh, we can see you well. Your screen is quite clear. Yeah, there you go. That's Dr. Mane for us. He's an anesthesiologist. And
I'm his PG, sir.
Okay. Fine. Dr. Sharon, would you share your screen once, please?
Shall I share my screen?
Yeah, just to see if it works fine.
Okay. Am I able to share it on a presenter view?
Yeah, presenter view.
Okay, just give me a second. I'm a bit slow with this here. Share screen.
there'll be a small arrow mark for
Dr. Sharon.
sharing.
Right at the bottom, you'll have share screen.
Yeah, it's asking me for system preferences.
No, if you have a keynote presentation, it will not share. It has to be a PPT presentation. So
it
you
is a
need-
PowerPoint.
Yeah, then it will share.
So should I share my desktop, isn't it?
Yes. Share
Yes.
your screen. There's a green icon right at the bottom.
I've got that, but it's taking me to, it's asking me to allow Zoom to share my screen. And then it's taking me to my system preferences. I think it's a firewall thing, I think.
One second. There you go. There you go. Share now. Can you share now?
Go to Zoom. Go to, okay. Haha.
Oh,
Yes, you got it.
Aha.
yes,
Okay.
yes.
You got
Perfect,
it.
perfect. Yeah, done. Dr. Hemfrisch, would you like
Yes.
to speak? Just to see if it works well, seamlessly?
You want to see my show as well, my slideshow?
Yeah, just to see if it is sharing, if there are no hiccups around there.
Screen sharing starting for my so. And now, what's the matter? Just a second, it worked so well. No, but it's not the full screen yet, huh?
Yeah, you need to just go up to the
Okay,
icon and
now
then
I have
select
it.
for the full
Yeah,
screen.
right. Yeah.
Okay,
Yeah, you got it. Good.
Good.
So
That's
you know.
perfectly fine, sir.
Perfect.
Yes,
just
yes.
a second. I have to.
Yeah.
Okay, this is it.
Perfect.
It does work well. Yeah. So,
So I stop it now.
yes, sir. Yes, sir.
Yeah. Okay.
Stop it now.
Okay. Now I have it. Yeah.
Dr. Rajesh, would you like to check your screen once?
Nilesh, you can mute the other people who are not the speakers. You can mute them so that their background
okay.
sounds will be.
No, I'll mute everyone, sir.
Yeah. Keep Rajesh open.
Yeah, of course.
You have to really keep your fingers on this muting stuff because a lot of people background sounds will be there. So you can keep unmuting them, muting them.
Yes, sir. That's Rajesh Manjas's screen, sir. Sir, just to unmute, if you can press the space bar, it will unmute automatically and you can speak.
Yeah, so now we need the other colleagues. Who else has to come in? What about Kate?
Kate, she'll join at 4:30, sir.
4:30, perfect. Yeah, another couple of minutes. What about the other people?
I'll call Dr. Bhandakar and I'll ask.
Yeah, please call them up.
Yes. Hello. Yes, ma'am. Good evening. Ma'am, could you just join the link? All the speakers are online now. You can just join and we can share the screen once and see if everything works well. Then, yes. Sure. Sir, she's joining in 5 minutes, sir.
So just check out for the other colleagues.
Yes, sir.
Alex, if you need, you can take a break because we already seen, we don't want to keep you holding on the screen all the time. You can always take a break in between, Alex. And same with Sharon, to you too.
So, Kosna, I just go
you can take a
away
break.
for a moment
Yeah.
and then come back. Is that
come
okay?
back again. Yeah, that's okay.
Fine.
Perfect. Please. We know that you're connected to us. That's more than enough.
Perfectly all right.
Yeah.
Thank
Take
you
a break.
for being there
You
with
can
us.
always come. Thank you.
And we're looking forward to hearing you well, sir.
Yeah.
Hearing you soon, sir.
Hi, can you hear me?
Yeah, we can
Yes,
hear
sir.
you well.
I can.
sir. Yeah.
Tell me, what's the time in India at the moment?
It's 4:30 exactly
It's
now.
around
4:30.
PM.
So we've got 30 minutes, isn't it?
30 minutes.
Yes, you
Yes,
can.
sir.
Yeah, you can take a break.
All right. Thank you.
Thank you. You can take a break.
Bye.
I shall see you, sir. Sir, can you call Dr. Rakesh once? I think he doesn't have my number, so he's not picking up. हेलो हाँ मनीष आ जाओ ना यार हाँ 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 हाँ
Rakesh is just joining. I just spoke to him, Nilesh. He's just joining us.
Okay, sir. Actually, probably he didn't have my contact number. So he didn't pick up.
Yeah, that's it. Yeah. I just spoke to him. He's joining. Probably he'll be there.
Kate will be joining in a couple of minutes.
Yeah, so it's good that.
I'll message her once.
Yeah.
Actually, yesterday I underwent a major operation.
Let's. Oh, so sorry to hear that. Take care, but you're fine, comfortable, Nilesh?
Too much pain, sir. Actually, severe pain in the back.
It's a back. What was the problem?
It was a big cyst, sir, like this big.
Oh,
Spacious cyst.
on the spine. Uh-huh. So you took an oron or something?
Yeah.
Rakesh is not at come.
Sir, can you ask your fellows to join, sir? Just on a text.
Yeah, I'll call them. Not text. Call them. Kick them. You know me, Nilesh. In India, asking doesn't.
Yes, sir. Yes, sir. Yes, sir. We are on Zoom already. All the participants are on Zoom. Sir. All the speakers are on Zoom. Sir. Yeah, I can't see your this thing, sir. Can you just? Okay, got it. Got it. Yeah, yeah. I have admitted you. Sir. Yeah, I have admitted you. Sir. Sir, Kate is joining, sir. She's just sending to. Sir, please welcome Dr. Krishnan. He's the whole and soul in charge of Indian Association for Sleep Apnea Surgeons. Sir, he's the person who has contacted us with Kate. And Dr. Vijay, Dr. Ghosla is my mentor.
Oh, so nice.
He's the man behind this event.
Sure. Oh, nice. Thank you for arranging such a wonderful program. His mic is muted, I think.
Yeah, he will.
Doesn't work. Yes, I'm muted. I'm sorry. But please welcome. Thank you very much for your kind sayings. You're most welcome to join us and be a part of this gathering, all of
Great.
us. Thank you.
I'll just come back.
Yeah.
So Dr. Bhandarkar is joined, sir. And Dr. Kane is joined as well. Hello, Dr. Kane.
You can ask Dr. Rakesh to share his screen.
Yeah.
Rakesh? Hi. Could you share your screen so that we can know that it's working, please?
Hi, Abhilash.
Hello, good afternoon.
Hello, sir.
Hi, Abhilasha.
Good evening, Ghosla
Welcome.
sir. How are
Hi,
you, sir?
Abhilasha. Very well. Thank you. Welcome.
Thank you.
Welcome. Hi, Manish.
Sir, good afternoon.
Welcome. Good
Good afternoon.
afternoon,
Hello.
Manish. Welcome.
Thank you, sir. Thank you.
Hello,
Hi, Manish.
Nilesh.
Welcome.
Hello, ma'am. Hello.
Rajesh. So nice to see you.
Yeah, nice to see you.
You can ask Dr. Rakesh Kayan to share his screen so that we know it's working.
Can you hear me? This is Nilesh from. This is Nilesh here, sir. His phone seems to be.
He has two numbers. Call the second number.
Yeah.
It starts with the 9.
I got that number. Ma'am has joined us. Ma'am, can you hear me? Manisha, ma'am, can you hear me?
Yes, yes.
Manisha, ma'am, can you hear me?
I don't think so. She's here.
She's here. She's here. Arya Bhandarkar. She's joined us.
Okay. Yeah.
Can you hear me?
Yes.
Yes, ma'am.
hello.
Yes, ma'am.
Can you
Yeah,
share your
hello
screen for us to check if it is working well?
Yeah, you want me to share the screen?
Correct.
Okay.
Yes. Perfectly all right. Perfectly all right. Yeah.
Yeah.
Very good. Yes.
Shall I stop sharing now?
Yes, ma'am.
Can you just enlarge it, madam, so that we know it's
full screen?
Get the full screen, please.
Viewers mode.
Yeah.
Yeah.
Viewers.
Yes.
Yeah.
Perfect.
Okay.
Ma'am, can you switch on your video so that we can wish you well, all of us?
Yeah. Okay. 1 minute. Where is the video? There we go.
It's perfect, ma'am. Welcome,
Yeah.
ma'am. Very kind of you to join us.
Thank you. Good to see you all.
On a short notice.
Hello, ma'am.
Hello. Hi.
Join the meeting. And, very nice.
I'll call up Kotra Shetty. He's still not joined.
It's very important to get the perspective of a neonatologist in this field.
Yeah, that's what I asked you in the morning. Who are going to be the audience? I realized that I'm going to talk to a bunch of surgeons.
But 99 of them will be surgeons.
Yeah.
One will be a neonatologist. And one is an anesthesiologist. So
Yes.
98 will be surgeons.
Yeah. Hello, Dr. Rajesh. Yeah. He's the only familiar face for me here right now.
Yeah. Hi, Dr. Manisha.
Hi.
Nice to see you on this panel.
Yeah. Thank you. Nice to see you all as well.
Dr. Rakesh, can you hear me? Hello? Sir, this is Nilesh here, sir. Yes, sorry.
Yes, tell me. Sorry.
Sir, okay. Sir, yes. Yes. Just now, if you can share one, sir, so that we will know.
Nilesh? Nilesh?
He's on
Nilesh?
call, I guess, sir. Sir, he's on phone.
Oh, sorry. Phone. Yes. I think we need to ask him to start muting everyone other than himself, He has to handle that.
Right,
muting
sir.
everyone.
Array. See who is there. See.
Yes, sir. I was just talking to Dr. Kane. So he said
He's able to share his screen.
He's unable to share his screen. So he's sending me his presentation. I'll share it on his behalf.
Okay.
Yeah.
Fine. Good. Yeah. And best is you can main is to control all the muting of other people because of the background noises.
Except you and me as of now.
No, you should be there to control it.
Yeah, yes.
Sometimes in between someone will getting unmuted, so make sure you keep checking that and
yes, it
muting
becomes
them.
it causes an echo. Can someone check if we are going live on YouTube and connection is okay?
You can ask Abhilasha. She's very good at this. Please, Abhilasha.
She is going to take questions from YouTube.
YouTube. Okay, good. So put Abhilasha onto it.
Yeah, she's going to take.
Yes, sir. Yes, sir.
There is a mild lag between Zoom and YouTube. There's like a couple of seconds lag.
Yeah, we are on.
Good.
We have Dr. Kotra Shetty who's joined us now.
Good.
Yes, sir.
Yeah.
He's here. Kotra sir, can you switch on your video, please? Good evening, sir.
Hi, Kotra.
It takes some time for the audio to connect.
Yeah.
Just 15 minutes to go.
Am I audible now, Nilesh?
Oh, yes, sir. Very well.
Yes,
sir.
Kotra.
Yeah.
Welcome,
Good evening,
Kotra.
Costa. Good evening. Good evening.
Hi,
good evening,
hi.
guys.
Good
Hi.
evening.
Good evening, sir.
Good evening, Abhilasha. Good evening.
Good evening, Kotra.
Hi, good evening. Rajesh, good evening.
Yeah, good evening.
Has everybody joined in? Nilesh already?
Yes, sir. Just like we already have some, 20, 30 people online.
Okay.
And more and more people are joining.
Okay.
Sir, good evening.
Hi, good evening. How are you doing?
Fine, sir.
Nice to see you all back again. Yeah. It's
Yes,
been quite some time.
Yes, sir.
Yeah.
Good evening, Dr. Kotra Shetty.
Good
And
evening,
thank
madam.
you for inviting
Madam,
me
it's
for
my
this.
pleasure to invite you all, such eminent people, on this webinar. Thanks for your acceptance and joining us for this meet. Thank you so much.
Thank you. Thank you.
Dr. Kane is now finally admitted now, sir.
So Kane is in.
Yeah, there he goes. Yeah.
There he goes. He comes.
Dr. Nilesh,
Yes, yes.
just keep 2 slots vacant. Don't admit 100 participants. Just in case if somebody is, logged out of the Zoom, you can admit them again.
Oh, okay. We still have.
So
we are
the speakers, especially, keeping slots open for speakers is important.
Yes, yes. Dr. Kane, welcome to the meeting, and thank you for joining us on this webinar. Sir, could you share your screen once? Dr. Kane? Sir, you can unmute yourself, Dr. Kane. You can just press the space bar and you can unmute. We still are.
You can do it for him.
Yeah, I can do it for him. Dr. Kane, can you hear me now? Dr. Kane?
Yeah, I can hear you, Nilesh. How are you? Video is stopped.
Dr. Kane, can you hear me now?
Yeah, I can hear you, but I'm not visible on the screen, neither you.
No, we can see you, Rakesh, but your voice is breaking. It's not that clear.
Okay, but now it's clear?
No, it's still coming very husky. Echo, lot of echo.
Okay, but I can't help it. What I can do from here?
You can keep the device little closer to you, sir.
Okay. Now it's clear?
Yes, sir. It's better now.
Okay.
Can you share your screen now, sir?
Okay, I can hear you.
Can you share your screen, sir?
Stop video share. Mute. Participant more. Leave. Voice. Zoom. Nothing. From where to share this video? Video is on. Share. Wonder.
I got your presentation. Let me share it on your behalf, sir.
Okay. Check it, please.
Just 1 minute. I'll download it on my computer.
But Nilesh, it's not visible anything on his screen.
Yeah, I can see you, sir.
Hello.
I just need to download
Okay.
the presentation.
It's all right.
So
Okay, okay.
it's just
It's
downloading.
all right.
So once
Yeah,
I
yeah.
download it, I will share it for you. Just
Okay,
going.
thank you.
Yeah. This PPT takes a while to download on the computer.
Yeah, yeah. ना बीच बीच में इंटरप्ट होता है ये वो नेट
Sir, Dr. Rakesh, can you see the screen?
Yeah, I can see it now.
Okay. So as and when your talk starts, and you can tell me keep changing the slides, I can keep changing for you.
Yeah, sure.
Okay.
So we have all the speakers online, isn't it, Nilesh? No?
Kate is there, not here. So I just remind her of Kate.
Yeah.
Maybe she's here. I need to. Hello. Yeah. Okay. Kate is just joining, so just in a couple of seconds. Sir, Kate is joined, sir.
Can we ask her to share the screen and check it out?
Yes.
Nilesh, you may have to stop your screen sharing so that.
Something is wrong with my Zoom.
என்னப்பா இது? Oh my God.
Something is wrong with my screen. Come on, yeah. Come on. What's wrong? Vijayan sir, can you send me how to, like, my screen is minimized actually. I can't see myself.
Can you see that stop share?
Yeah, I stopped it. It says resume share. Can you see me actually?
Yes, we can see you.
And are you seeing my screen?
No,
Yes.
still we are seeing your screen.
Screen is still visible.
You may have to leave the meeting and join again. Maybe you may have to make someone else host and then you have to leave.
But, okay, yeah, that's the best thing to do.
Just make Abhilasha as a host, Nilesh. Put Abhilasha as a host.
Actually, sir, something is gone missing from my screen.
We can see you now, Nilesh.
Yeah, but I can't see my screen, sir.
I feel it got stuck because even the screen looks like as if it is minimizing.
Yeah. Okay, no problem, Nilesh. What you can do is you can leave the meeting automatically. Someone will become host, so we can admit you, and again you can be the host. No issues.
There is no leave meeting option actually. There is only an option which says that
Somewhere you can see a cross. Just click on that cross. Don't end the meeting. Just you leave the meeting.
sir, what nonsense is it? There's nothing like that. This thing is not coming down, you know.
No, I think you have to make someone as a co-host before leaving.
Actually, I cannot see the bar, so that's what is going wrong. If I have to make someone a co-host, I have to.
Now your screen is yes.
I got it. Yeah. Okay. Yeah, there I go. Yes.
Done.
I don't know how it happened, but it happened. Hi, Kate. So nice to see you here. And may I request you to please share your screen so that we can just have a sample run, test run, and then we can start ahead with the meeting in 5 minutes.
Sure, thank you. Nice to see you all.
Thank you so much.
Okay, I'm sharing my screen now.
Please do, ma'am. Oh, wow. There you go.
Great.
Okay.
Yes, perfect. Perfectly all right.
Okay. Yeah.
Fine. I think, is there any audio in your presentation?
I didn't put any videos in. I'll talk over it.
Yeah, that's better actually. You know, sometimes this video gets stuck very badly.
Yeah.
My suggestion, Nilesh, again, you may get hang by the PowerPoint presentation. So you can make someone else, maybe Abhilasha, maybe a co-host, so that she can sort out the issue right now.
The thing is that package is for one host. Let me make her a host and
co-host. You can make co-host one more.
Okay, let me see. Just says change host. It take only one host. Sir.
Co-host. Is there an option of co-host, Nilesh?
There's no option. So Abhilasha, I'm going to share the PPT with you. You download the PPT and you share it when it comes. Okay.
Okay.
Sir, it's 5. Sir, it's 5. Shall we start?
Yeah, I think you should start, Nilesh. Please invite everyone and then you can start. Start with the first speaker.
Yes, sir. So it gives me a immense pleasure to welcome you all for this webinar on Pair-Robin syndrome, its management, and its different perspective from the point of view of neonatologist, anesthesiologist, conservative management, ENT perspective, maxillofacial perspective, and so that we can come to a common minimum understanding as to how to approach these patients who are really, really complex, just to put it in very simple words. So we have a galaxy of speakers from all the fields, and it's my pleasure and real privilege to be hosting this meeting on behalf of GSR Institute under the guidance of Dr. Gosla Reddy sir and Kotra Shetty sir. And without we really have very short time, so let's get going with the first speaker. That is Dr. Manisha Bhandarkar. She's a consultant neonatologist. She's at KLE Dr. Prabhakar Core Hospital, and she's a professor of pediatrics in JNMC Belgaum. Ma'am is going to talk to us about her experience, her viewpoints about managing these patients, because neonatologists are the first responders for these. And definitely, as surgeons, we need to know what's their perspective and how we can work together in collaboration with the neonatologist and opinion regarding these patients and initial few days, which are most critical in a long-term sustained treatment for these babies. So, ma'am, would you start sharing your screen and take over from take over the presentation and enlighten us with neonatologist perspective? In the meantime, I'm going to mute everyone's audio so that there is no echo. And ma'am, you can just press the space bar and start speaking.
Hello, am I audible?
It's a little low, ma'am. Can you increase the volume? Go full screen, ma'am, please.
Yeah. Yeah. Can you hear me now?
It's low, ma'am, but we can hear you.
Clear now?
Yeah, better.
Okay. All right. Okay. Yeah. So good evening. And at the outset, let me thank the organizers, especially Dr. Kotra Shetty, for inviting me to join this today's meeting, a galaxy of surgeons who have joined over here. And me as a neonatologist, what I would need to say regarding the initial assessment and neonatal care for Pierre-Robin sequence. So I bring greetings to you from Jawaharlal Nehru Medical College, Belgaum, and the Dr. Prabhakar Kore Hospital and Medical Research Center, where I'm working as a consultant neonatologist. Okay. So, yeah. So I needn't say much about Pierre-Robin sequence over here. As such, you all are the most experienced faculty who have been dealing with it in and out. Me as a neonatologist, coming across a case of Pierre-Robin sequence, wherein the incidence is somewhere between 1 in 4,000 to 8,500. In my last 15 years of experience, probably I would say, we do see a case of Pierre-Robin sequence wherein we see all the features of it, which includes micrognatha, glossoptosis, and airway obstruction, with or without a cleft palate, maybe once or twice a year. And when we struggle really to decide what about the further management. So let me be very clear here at the outset is we really don't have an exact protocol in place of what to do exactly when for a case of Pierre-Robin sequence, but we do have a protocol in place what to do when there is an airway obstruction. So that is what I'm going to share my experience with you all today. We all know that it may be an isolated anomaly or it could be in conjunction with a syndrome, and it was first described by Pierre Robin somewhere in 1934, and now it's a preferred terminology as a Robin sequence. It could be a part of a broader syndrome in around 25 to 46% of the cases. And the cause, yet not very, whatever is known so far, is probably there is some primary growth disturbance somewhere around 9 weeks in utero, which is thought to be the inciting factor for this Pierre-Robin sequence, which leads to primary growth disturbance, which could be because of the primary growth disturbance or the hyperflexion of the neck. Majority of these are probably non-syndromic though. Now, when we think about evaluation of a baby with PRS, it's a multidisciplinary approach. And if I start somewhere from perinatology and neonatology, and then there are a whole lot of people who are involved in this multidisciplinary care, which includes the pulmonary or sleep medicine, specialists, developmental pediatrics, plastic surgery, oral and maxillofacial surgeons, orthodontics, ENT specialists, geneticists, speech therapists, cardiologists, audiologists, urologists. It all depends upon what are the problems that the baby is born with. But let me speak a little more about what would be a perinatologist doing if we have a case of when we are faced with this problem. The initial diagnosis of Robin sequence could be where the perinatologist is of great importance, and it could be done either by ultrasonography or MRI, and or wherein there is a high index of suspicion if there is a previous sibling is affected. Whereas what a neonatologist is going to do is initial recognition. Yes, there is a case this with Robin sequence, the stabilization of the baby, the coordination of care in the early management of airway obstruction and feeding dysfunction, and identification of the associated conditions. So as rightly said by Dr. Nilesh earlier, is we are the people who first see this baby after birth, and we need to look at not just the care of airway, but what other problems the baby is born with, and is it associated with any other syndromes. So whether it's a syndromic or a non-syndromic baby is somewhere where we have we need to determine right at the beginning of our care. So what can a perinatologist do? High resolution ultrasonography initially during antenatal period can help to diagnose micrognathia, and this could be done as early as in second trimester of pregnancy. Can they for sure diagnose a case of Pierre-Robin sequence? Well, when I was just going through some literature search, I came across various algorithms for prenatal diagnosis of Robin sequence based on inferior facial angle, fetal jaw size, micrognathia, and the degree of glossoptosis. Jaw index is being thought of. Fetal MRI of the mandible is being considered when there is severe micrognathia. But I couldn't find in the literature if there is a standard algorithm for screening of a baby with PRS if it has been if they have come out with. But what is the importance of all this prenatal evaluation? Basically, because it's important to counsel the family for the challenges after birth. See, when a family is looking forward to inviting a baby, no parent is ever mentally prepared to receive a baby with multiple problems. But if that is something which is antenatally diagnosed and the family is counseled about it, it becomes much, much easier for us as neonatologists to talk to them, to counsel them, and not just them, to prepare ourselves for any airway emergency in the delivery room. Some literature has shown that presence of prematurity, low birth weight, neurologic abnormalities, if they have been detected on ultrasound during the antenatal period, and if it's a presence of a known syndrome, these are all risk factors which we neonatologists have to be aware about, that okay, this is a case of a Pierre Robin sequence and there is low birth weight or there are associated neurologic abnormalities. I'm expecting trouble over here. I need to keep my team ready, and not just the team, all the necessary equipments to take care of this baby. And presence of polyhydramnios antenatally also is a big additional risk factor that has been suggested in the published literature. So our challenge is taking care of the airway initially, immediately after birth. And the second big challenge is the feeding. So how do I prepare myself if I'm going to, if I'm expecting a baby who has Pierre Robin sequence, if I know antenatally detected, then definitely I would make sure that I have the personnel and the equipment ready in the delivery room. So I need at least 2 people who are trained in the neonatal resuscitation to be there in the delivery room, who know not just the basic but the advanced resuscitation. This delivery should happen in a tertiary care hospital where all these facilities are available and the excuse me, and the hospital even has the equipment necessary for the neonatal resuscitation, which means that not just the initial steps wherein we may try with CPAP in the delivery room using a TP's resuscitator, or a laryngeal mask airway intubation. I'm sure Dr. Mane is going to talk about it as an anesthetist a little later. And if to have such a baby delivered in the middle of the night, wherein we are not at all aware of what we are expecting, and which happens most of the time, it is a neonatologist's nightmare. Because to have a team ready of a pediatric surgeon, ENT surgeon, even the anesthetist who is trained in case we need to in difficult intubation, to have this team ready in the middle of the night is so difficult, and it is really our nightmare to have to face such a baby in the delivery room. And I have undergone this experience at least twice, and it takes it's a lot stressful. Not on one side we have to ensure that we are doing the best for the baby, and at the other side we have to take care of the family as well, and counsel them of what's expected ahead. So preparation for birth is something which I would stress a lot upon. Antenatal diagnosis, very, very important, and counseling the family if we have the antenatal diagnosis. So how do we go about when we have such a case? First of all, the initial stabilization and care. We follow our routine neonatal resuscitation program guidelines for this, and which includes maintenance of the temperature, so receiving the baby under the warmer, taking care of the airway. We will discuss about it a little later, breathing, circulation. So we follow the same, but we have a proper neonatal resuscitation program, which helps us to decide where, at what time we should do what. So receiving the baby immediately after birth onto the resuscitation trolley, drying the baby, ensuring connecting it to the temperature probe to maintain the temperature. These are the initial things which we have to do. And then comes the airway. So especially whatever in my experience, whatever I have handled the cases, probably most of the cases we have been able to manage with a delivery room CPAP, not really needing intubation. And the second thing is with prone position. So initial care of clearing the airway, positioning the baby. In our routine positioning, we put them supine. But when you have this problem, especially where there is clear evidence of Pierre-Robin sequence, and along with that glossoptosis, and we can see that the tongue is obstructing the airway, then putting the baby in the prone position in the delivery room immediately after birth has helped in ensuring that the baby's airway is maintained, and the baby, we help the baby with the breathing. The rest of the process of resuscitation goes on as per the NRP, NRP program that we follow. So after establishing of the breathing, then taking care during simultaneously taking care of the circulation of the baby, and then whatever we have to go use of medications if at all needed to help the baby in the delivery room, we would be following the same protocol even for a baby with a Pierre-Robin sequence. What decides how we are going to support the baby with the breathing depends upon the severity with which the baby is born. So a baby may be born vigorous and crying, and then we really may not need to do anything for this baby. Just clear the airway, put the baby in prone position, give supplemental oxygen, ensure that the oxygen saturations are as per the NRP guidelines, and then shift this baby to the NICU. But if there is mild to severe respiratory distress, according to whatever the severity of the obstruction, we will need to take this steps to ensure that the airway is patent. So this would maybe positioning. The next step is providing CPAP using the TP's resuscitator. The third thing is probably using the oropharyngeal airway, which I have used once in the delivery room, which has helped us to keep the airway patent. And the last option would be intubation. Now, intubation is tricky, and I'm not going to talk much about it here because we have an anesthetist who would be talking about it. But the positioning of the baby and intubation is what is quite tricky in case of baby with Pierre-Robin sequence. Use of laryngeal mask airway is another option. I have personally not used it, but that is what is suggested. But of course, it is a transitional period during which using that LMA to keep the airway patent that we can use in the delivery room. If the baby may present to us with severe cyanosis, if there is a structural cyanotic heart disease, so the baby in the labor room will have the distress as well as cyanosis, which is not improving in spite of providing adequate oxygenation. So even after getting the airway sorted, we give oxygen, still the cyanosis is not improving. We may need to think of a structural cyanotic heart disease, or we may have an absolutely hypotonic baby because of neurological involvement. And in spite of we helping to for the baby to help with the breathing, because of hypotonia, baby may not be able to support itself, and then that is when intubation, ventilation comes into picture. So clinical assessment of the airway compromise is what helps us right in the beginning. We may have a baby who may have no distress, to apneas, to severe distress. So an assessment of severity of distress, we do basically subjectively based on the presence of stridor, presence of chest and neck retractions in the supine position, whether it gets corrected when the baby goes into prone position, which is what we have seen mostly, increased use of accessory muscles, presence of cyanosis, and finally, if it's respiratory insufficiency, then we don't have any other opinion but to intubate the baby. We usually start with putting the baby in sidelining or prone position to see if the obstruction resolves. If that doesn't work, then next we consider putting an oropharyngeal airway, and also nasopharyngeal airway we have not considered, but that is what the literature has said. And the next is to consider intubation if it doesn't help. We have also seen there is positional oxygen desaturations in these babies, so we put them in prone and the saturations improve. So that is also something we have seen in the delivery room in these cases. That is one of the ways we use to help them maintain the oxygen saturation. The baby may be have other syndromes associated. So it may be just Pierre-Robin or associated with syndromes which can have choanal atresia, pharyngomalacia. Laryngomalacia is quite common that we have seen. Subglottic stenosis, yes, I have experienced one case, tracheomalacia, bronchomalacia, tracheal stenosis. So this needing ultimately tracheostomy in the delivery room. In the last 3 years, we have done tracheostomy in the delivery room itself, but these particular babies were not exactly Pierre-Robin sequence. They were more of isolated anomalies, but we had to do the tracheostomy in the delivery room itself. The objective assessment, of course, you all know, is using of flexible nasopharyngoscopy, bronchoscopy, and polysomnography, video swallow study. So all those things, but they can be all later on. They don't help us in the labor room. A labor room, we have just this emergency of trying to maintain the baby's airway. Once that is done and baby is shifted to the NICU, then comes the further management of the breathing as well as the feeding aspects. So how do we manage this baby in the NICU? Of course, putting an IV line, maintaining the temperature, taking care of the asepsis, considering antibiotics if there are risk factors for so. If the baby is born premature, then care for prematurity. If it's low birth weight, then care for low birth weight. All these things as per the protocol comes into picture. Along with that, literature says prone positioning, the success rate is more than it's nearly 44 to 69%. Most of the cases which we have seen in our NICU, we have had good results with prone positioning. But if there is persistent obstruction in spite of being in prone position, the next option for us is to give nasal CPAP. That has also helped, but we do have difficulty in positioning the mask on the baby's face, because as it is, there is so much of the cleft lip, cleft palate, the nasal cavity is not well formed, but still it has helped us in maintaining the airway. Nasopharyngeal airway is can be done, but I personally don't have much experience with that. And endoscopy as an intubation aid also has been shown, but we have not done it in our NICU. The second important thing, as we are trying to maintain this airway, patent airway and oxygen saturations immediately after shifting to the NICU, we also do a proper head-to-toe examination to look out what other anomalies are associated along with this. So that is what determines what should be done next. Do we need to do an immediate echocardiography? Do I need to do a cranial ultrasound? Do I need to do an X-ray chest? So we determine what other investigations have to be done. Serial blood gases, if there is, we are really struggling with obstruction and airway obstruction, if we are struggling with oxygen saturation, then we need to start doing the blood gases. But it is not just over here. We need to do serial blood gases if we are considering later on in the after the initial stabilization of the baby. Also, if we are looking at a chronic airway obstruction, then because of this chronic airway obstruction, we may see the CO2 rise. If the CO2 rises, then we will need to again help the baby with a nasal CPAP to keep the airway patent. So the blood gases are both to look at the hypoxia and if there is any CO2 rise in this baby during the NICU stay. The second and most another difficulty we face is feeding these babies. Now, after feeding, of course, we consider after stabilization of breathing and optimal oxygen saturation. In case of mild PRS, we have seen many babies are comfortable with latching and even with direct breastfeeding. Sometimes the nurses themselves are not confident whether the baby could be put to the mother's breast for sucking. I try to look at the literature to see whether there are how many reported cases of successful exclusive breastfeeding in babies with Pierre-Robin sequence. I couldn't find much literature on it, but with our personal experience, what we have found is babies whom we think that the baby has a complete cleft palate and may not be able to latch on. But if the baby has a good suck reflex and we put the baby to the breast, we see them they are very comfortable with latching and they start taking the direct breastfeeding, and that takes care of the feeding issue, which is a major issue later on. If not, using of Haberman and pigeon feeder is another option which is there. in Indian setup, to use all this is a real challenge, because to maintain asepsis, to teach the parents how to use it, that is a real challenge in case of Indian setup. But it can be used and it has been found successful. That's what has been reported. In case of moderate to severe distress, if it is associated, then we need to consider tube feeding. So if there is moderate to severe distress, we start with orogastric feeding of the express breast milk or formula, and then once the baby's distress is settled, then we try putting the baby to the mother's breast and then to establish the exclusive breastfeeding. Around 8 to 62%, this is what literature says, that Pierre Robin sequence babies, they require supplemental tube feedings. Nasogastric tube or a gastrostomy tube in case of chronic feeding difficulty may need to be considered. But what we try in NICU is we start with orogastric feeding and establish the base, so that make sure that the baby goes on to the full feeding. After the breathing and feeding has been settled, then we need to, what is the further monitoring in the NICU? We'll need to look for the weight gain, because this baby is struggling because of its obstruction. And if the baby is low birth weight, again, we need to ensure that baby gets proper calories and proteins. So we need to ensure that the feeding is adequate, give supplementation or human milk fortification we may need to do to ensure the calorie, protein, calcium, iron intake of this baby. Oxygen saturation by pulse oximetry is absolutely essential in the initial few days. And if the baby is absolutely comfortable, then we teach the mother how to put the baby in the prone position, how to watch for the baby's increasing distress or change in color, because home monitoring using pulse oximeter, though it may be done in in the metros, in a place where I work, that is something which we cannot think of, sending the baby home on pulse oximeter. So we haven't done it so far, but that can be possible. That is another options that can be considered if we have a baby who needs constant monitoring from apneas, hypopnea, and the quantity of feeds and supplemental fortification. Surgical interventions I'm not going to talk about. So what is the way forward for these babies for treatment of this Pierre Robin sequence? Is this one study, which interesting study is using, which has been published in 2017, which I found. Basically what we don't need to look at is the obstructive apnea hypopnea index. So if these babies, this would be done using polysomnography, and what we look at is what are the events of apnea and hypopnea these babies face during the 24 hours monitoring. And if the events are more than 2 events per hour of sleep, but less than 5, it is called as mild obstructive sleep apnea. If it is between 5 to 10, it is moderate, and if it is more than 10, it is obstructive sleep apnea. So if this is something which we can do in our setup, this is what I thought would definitely help us to improve the care of these babies in deciding what should be the care, even what should be the monitoring even after sending this home. What is the importance of this obstructive sleep apnea? Is basically what will happen is, if the babies are suffering from this, then they will have chronic obstruction and consequent carbon dioxide retention. This affects the respiratory system. It can cause pulmonary vasoconstriction, hypertension, leading to later on, if it is not detected, then baby can present to us with right ventricular failure. Not just that, it has been also shown to be associated with later on neurodevelopment of the baby also, which can be impaired if there is chronic hypoxia and carbon dioxide retention in babies. So this is something which we need to look forward to if we can introduce, even especially in Indian setup. So if we are looking at what complications after discharging these babies home, we need to teach the parents for is what the surgeons are going to do about it, which will come later on. But what me as a neonatologist would be interested in ensuring that I teach the parents how to prevent gastroesophageal reflux, so that after feeding, this baby is not immediately put down in supine position. At least they keep the baby in 45-degree position for some time, so that the reflux is avoided, chronic aspiration is avoided. How to look for hypoxia, how to look for change in color, a regular follow-up of this baby, especially for growth and development. What I have seen in our setup is that these baby, we lose these babies for regular follow-up for growth and development. We are not just looking at survival of these babies, we are looking at intact survival of these babies, which includes multidisciplinary approach. And it's not just the neonatologist, but the developmental pediatrician also gets involved in this. So a follow-up, regular follow-up of these babies in the high-risk follow-up clinic, which is run by most of the neonatologists, is very, very essential. And my really request to all the surgeons who follow up these babies is to ensure that these babies do get followed up in this high-risk clinic, so that they don't miss on the early intervention which can be provided. So this would be not just in terms of speech therapist, audiologist, but we would be looking at the overall development, nutrition of the children, and providing early intervention, training the parents how to stimulate these children later on in life. So you all very well know what all the syndromes these babies could be associated with, and that is why a head-to-toe examination is very, very important for us to look out what are the syndromes, if there is association with any syndrome. So home cardiac apnea monitoring in prone positioning during sleep is after discharge is something which would be very, very essential, but may not be possible in our setup. A high risk clinic follow-up, early stimulation. We do mostly a subjective assessment of severity of the whole Pierre-Robin sequence, because we don't have all the facilities to do all these assessments. And one more thing we just tell, we need to talk to the parents about prone positioning. When we talk about prone positioning, when is there a risk of seeds? But so that is something which we are, we have the benefits of prone position, as well as the issues that could come along with that. So that is something we will need to talk to the parents about. This is something which I'm sure you all must have known about, this study which has been published, and this is a very senior faculty who has experience in taking care of neonates with Pierre-Robin sequence, has given this flow chart of when to decide what intervention to be done in case in these babies with Pierre-Robin sequence. So and it's a busy slide, and I cannot go through the whole slide right now, but it has sort of given guidelines. If you have all the facilities, then how can we go ahead with monitoring of these babies in the NICU and later on post discharge also. So with this, I hope I don't know, I may have overshot the time that was given to me. Thank you very much. I mean, there could have been a lot more that I could have discussed, but this is what I would say from a neonatologist perspective. Delivery room, it's a big challenge for us, especially when we have a baby with severe airway obstruction. In the NICU, taking care of the airway and the feeding problem of these babies, and post discharge to ensuring that these babies, they develop well, their growth and development is adequate, so that you as surgeons can ensure that you can intervene successfully. Thank you very much for the listening.
Ma'am, thank you so much for your enlightening lecture for us, especially the neonatologist perspective. Ma'am has another meeting to attend. So if there are any questions to her, we can take the questions now. And one of the participants on YouTube has asked a question. Ma'am, can I ask the question to you?
Sure, please go ahead.
The question is, how do you, is there a way to anticipate prenatally, like, where you can be sure, you can anticipate that this baby on a prenatal scan we can assess whether this baby will require tracheostomy or not at birth, or in the early days of birth?
Yeah. So there was just one slide which I had put about it. I am not a perinatologist, but the antenatal ultrasound, it really needs a high index of suspicion to recognize micrognathia. And if this micrognathia is, there are some in jaw index which determines how significant is this micrognathia, which can, if it is diagnosed antenatally, then it could be of great help for us to determine how much is the risk factor. Secondly, if it is associated with polyhydramnios, that also there is been mentioned that it could be another high risk factor for us to consider, that this baby may need advanced resuscitation in the delivery room immediately after birth. So along with this, if there is antenatally detected intrauterine growth restriction, that puts the baby at risk of needing advanced resuscitation. And if it's a preterm birth, then the problems of prematurity itself, such as surfactant deficiency, can add on to the already existing airway obstruction in these babies. So I think it would be as a neonatologist, I would look at if these are if this is what is reported in the antenatal ultrasound, and if these are present, then I would keep myself ready for advanced resuscitation, ensuring that I have standby help for tracheostomy as well if needed.
Thank you, ma'am. Thank you so much. It was a privilege for us to have you on board for this webinar, and wish you safe stay during this pandemic.
Thank you very much, and thanks for giving me this opportunity. I hope it was useful. Yeah.
Absolutely, certainly. To continue with our webinar, next we have is Dr. Rajesh Mane. He is the HOD of anesthesiologists in the same Belgaum, Jawaharlal Nehru Medical College, Belgaum. He has huge experience of in the field of anesthesia, about 25 years. He has presentations, guest lectures, and publications all across the world. And his main area of interest is critical care, difficult airway management, and of course regional anesthesia. So, sir, it gives me an immense pleasure to welcome you and enlighten us on the difficulties you face when a surgeon approaches you to that a surgeon wants to operate this baby. So, what are the first thing which clicks you, and how do you manage the perioperative time, and what are the tips and secrets we can share with our anesthetists, to be ready for the worst possible scenarios. So over to you, sir.
Thanks, Nilesh, for the introduction. Hope you can see my screen and I'm audible.
Absolutely, sir. Everything is crisp and clear, sir.
Okay, thank you. Good evening, everyone, especially the director of GSR, Dr. Ghosla, Dr. Pottashetty, and other panelists, and also the galaxy of speakers for today's program. I come from the same place as Dr. Manisha. This is the hospital, Prabhakar Kore Hospital, where I work. I bring greetings from the Department of Anesthesia, JMC Belgavi. The initial part of my lecture is going to be the same as Dr. Manisha has already discussed, so I won't be going through this much. I'll try to skip as much as possible and deal with the anesthetic part much more. So as you know, it is nothing but the triad of these three symptoms and signs, basically micrognathia, glossoptosis, and area obstruction. Cleft palate can be an added feature of PRS. As said before, incidence varies from 1 to 5,000 to more than that. This is because there's a variation in the presentation of these babies. It can be mild, which can go unrecognized, to more severe ones, which come as with respiratory obstruction. This can be seen as an isolated anomaly also in combination with other syndromes like Stickler, bilocardiofacial, fetal alcohol syndrome, and Treacher-Collins syndrome, wherein there will be associated musculoskeletal disorders, cardiac disorders, and to some extent cervical spine pathology, which we need to be careful about. Well, as told before, it has basically two major features, clinical features, the concern with the respiratory and the feeding difficulties. Respiratory, as you know, will be associated with airway obstruction leading to respiratory distress, which can be seen in the form of stridor, retractions, and cyanosis. Well, the neonate and the infant, as said before, with PRS require care from multiple specialists in the initial care of these patients, and hence the anesthesiologist involved in the care of patients will interface with this multidisciplinary team of neonatologists, the surgeons, the ENT specialist, and the speech therapist. Well, basically the goals of managing these patients revolves around these three main factors. One is improving the feeding and swallowing issues, at the same time correcting the airway obstruction, which can ultimately lead to optimizing the growth of the baby as well as providing adequate nutrition. One thing what we should know here is feeding and airway are interlinked here. If you try to improve the feeding, it is not possible without correcting the airway. Similarly, correcting the airway obstruction may not totally relieve or help in feeding issues, because many a times what happens, the feeding and swallowing issues may lead to some amount of GE reflex, gastroesophageal reflux, which can be due to a little anomaly of the distal muscles. So what we need to do to overcome this feeding difficulties, as mentioned before, are these three factors: upright feeding techniques, then modification of bottle feeding, and ultimately nasogastric or oral gastric and gastrostomy feeding has to be done, as these patients are failure to thrive patients. Well, the airway compromise which we see in these type of patients can be classified from mild to moderate and severe. So depending upon different parameters, they can be classified. One is responding to prone positioning, as Madam Manisha has already told, or insertion of nasogastric tube, nasopharyngeal airways. So if the patient responds, then you classify it as a mild. If there's no response to these, then obviously you grade it as moderate to severe. Similarly, the other factors on visualization through flexible scope and direct laryngobronchoscopy, the apnea hypopnea index, presence of central apnea, associated neurologic comorbidities, or as I told you, gastroesophageal reflux, which can be medically stable or which can be refractory to medical line of management. So depending upon all these factors, you can classify the airway obstruction which can occur in these patients from mild to severe. So as all of you all know, airway obstruction that is mild can be corrected or certified by just prone positioning or by insertion of a nasopharyngeal airway. If it is moderate, then obviously you require a TLP or a MDOs. When it is severe, when there is a severe airway obstruction, obviously the first thing what you do is a tracheostomy and try to help the nutrition, the mandible to grow, and later on you can go for a delayed MDO, which is obviously maybe done by the surgeons later on in their talk. So coming to anesthetic management per se, these patients with PRS require anesthesia for a variety of procedures. The first thing is DLB, that is direct laryngobronchoscopy, to evaluate the degree of obstruction, also to see whether these patients can be difficult to intubate. So obviously this has to be done when these patients are posted for TLA MDO, and also in emergency tracheostomy cases. So basically challenges what we face are difficult intubation as it is. And when there's a difficult intubation, obviously the patients can have perioperative respiratory complications. And also we have to take in mind that these patients, because of chronic hypoxia and airway obstruction, will be opioid sensitive from these two conditions. So as you know, airway obstruction can exist at multiple levels. One, basically due to glossoptosis, because of the fall of the tongue, there will be oropharyngeal obstruction, and later on in the behind that, because the collapse of the epiglottis and base of the tongue, there could be hypopharyngeal obstruction. Further on, leading to lower down, it can also cause laryngomalacia as or subglottic or tracheal pathology, which can be present in these cases. So how do you evaluate these patients? So we need to have a proper history, perinatal history, depending upon the type of delivery the babies have been delivered. Also, the degree of apnea or cyanotic episodes in the early neonatal period, and the difficulty in feeding of these babies. So all this history has to be taken into consideration when you come across or evaluate these patients as far as airway is concerned. At the same time, you need to examine these babies in a variety of positions. As you know, when the patients are kept supine, they can have a significant history of airway obstruction. So you need to check these patients in different positions, from sitting position, then later on supine, prone positions, and evaluate the degree of obstruction and how much they can improve by differing the position. Also, at the same time, we need to know presence of obstructive sleep apnea by looking at the room air oxygen saturation and also by polysomnography. There are also an index called as Copper index, which we evaluate in case of pediatric patients regarding difficult airway. And other thing is flexible nasolaryngoscopy, as I mentioned, to know the exact site of obstruction and the degree of obstruction. So I hope the slide is clear. So depending upon the 5 parameters, the degree of hyperplasia of the chin, the opening of the mouth, any previous history of intubation, difficult intubation or OSA, then the visibility of uvula, and the different range of motions looking up and down. These are given a score from 1 to 4. And these are the prediction points for a difficult intubation or a difficult airway. So a score of 5 to 7 or 8 to 10 may to some extent have a easy or a near easy normal intubation. More than score of 12 obviously will lead to a difficult airway and a difficult case for intubation. Further on, to know the significant degree of obstruction, as in particular on the surgical perspective, to know the site of obstruction, these are the following investigations which can be done. One is flexible nasolaryngoscopy, CT scan, MRI, polysomnography and echography are done basically depending from case to case basis whenever the history of obstructive sleep apnea and when these patients are associated with associated syndromes and when there is a likelihood of a cardiac involvement, then you need to do an echo as well. On CT scan, you can know the exact degree of obstruction, which is very well known among all the surgeons here in the panel. So this is a grading of epiglottis and base of the tongue collapse. This is a picture how you usually see. There are 4 grades, and depending upon the grade, you are going to find the difficulty level of intubation. Well, coming to the airway management proper, a definitive airway obviously in these cases is challenging, and what we should know always is patients who cannot tolerate supine position are always difficult to mask ventilate. They always and require airway adjuncts such as nasopharyngeal airways and LMAs to provide anesthesia or provide ventilation. So we always and a must to have a difficult airway trolley at our bedside in the OT. These are common anesthetic drugs which we usually have with us when we come across a difficult airway scenario. Pre-medication, we usually give antisyllagogues, either glycopyrrolate and atropine. Then local anesthetic nebulization to obtune the reflexes of the larynx. Ketamine and dexmedetomidine are usually given because they are less likely to cause any sort of respiratory depression compared to the other agents, common agents, anesthetic agents. inhalation agent induction is always through inhalation agents. The reason is because inhalation agents try to maintain the spontaneous respiration. Because as you know, any induction with anesthetic agents, there is a likelihood of these patients going into apnea because of atonia of the muscles as well as any obstruction. So we tend to have induction mainly basically through inhalation agents, and the most common agent what we use is sevoflurane. Maintenance of anesthesia is usually through a short-acting opioids like fentanyl or sufentanil, and the same thing like dexmedetomidine can be continued. Neuromuscular blockade is only given in mild to moderate cases whenever you are sure that you are able to maintain the patient airway or the endotracheal tube is inserted and checked properly. So before we go to the anesthetic management proper, the anesthesia trolley, difficult airway trolley should be kept almost near the bedside in the OT. So I'll just like to tell you, bring to the notice of all the speakers here and participants. This is a trolley what we usually have. It has four drawers. On top of the trolley, we have the flexible fiber optic scope. In drawer 1, we have alternative laryngoscopes, airway adjuvants like bougies, different laryngoscopes, short handle laryngoscopes, a microblade laryngoscope, and a video laryngoscope. Drawer 2, we have the LMAs, different types of LMAs, the intubating LMAs, and the fiber optic adjuvants like intubating catheters. And in the other part of drawer 2, we have the different agents and the devices like the oropharyngeal airways and the local anesthetic drugs. Then in drawer 3 and drawer 4, we have the surgical cricothyrotomy and the cannula cricothyrotomy in case of emergencies when we come across any patients who are with whom we cannot intubate or ventilate. So this is how, whenever we come across a difficult airway, basically in PRS, we need to have a plan A, plan B. Okay, plan A, plan B is a must for all these cases. So in the first plan, we optimize the patient's position by giving a pillow under the head of the patients or under the shoulder of the patients. We have different laryngoscopes. We have a bougie. Then the second plan is LMA devices and fiber optic intubation. Then, depending upon the condition of the patient and how we face across, we need to go stepwise. And if at all we cannot intubate and cannot ventilate, then we have the cannula and the surgical cricothyrotomy available in this difficult cart. Coming to intubation for patients with PRH may be performed with a variety of techniques. These techniques can be performed in many patients without sedation, with sedation, or general anesthesia. Because many times we see patients with PRS already with the nasopharyngeal airway. Sometimes we see a tube in place because of the degree of obstruction at the neonatal or the early infant stage. So they'll be so much sedated that we just have to insert a LMA many a times, or we just do a fiber optic intubation in these cases. The hallmark of managing the known pediatric difficult airway under sedation and general anesthesia, as I mentioned before, is to maintain a spontaneous ventilation always. So these are different techniques depending upon the type of surgery and type of the degree of surgery. Either we maintain the patient on nasopharyngeal airways and LMAs. Sometimes, many times, we have to do a paraglossal laryngoscopy for intubation. In difficult cases, we do use video laryngoscopies, rigid bronchoscopies, and fiber optic scopes. This is the technique which is most commonly used in many places for intubation in a PRS patients, called as paraglossal approach, wherein the laryngoscope is placed on the right side of the patient's mouth and visualized what advantage it gives is it reduces the distance from to and into the glottic opening. Only thing is the space along this right side of the mouth is reduced, thus passing the tube may be a little difficult. Fiber optic scope is the gold standard for any difficult airway case. So it is in a pediatric patients with PRS as well. It can be done either through nasally or orally. Orally, basically it is done through an LMA. Okay. Nasally, what happens? We have to pass a nasopharyngeal airway in through one of the nares, which can be used as a conduit to maintain or provide anesthesia. Basically, the volatile anesthetic agents, for example, sevoflurane with oxygen. The scope is then passed through the other nostril to visualize the glottis, while an ET tube can be passed orally or nasally. Then spontaneous ventilation is maintained. Basically, as I told you, with sevoflurane, many of the centers we use propofol in moderate doses or incremental doses. As I told you, LMA can be placed awake also in severe obstruction. So what happens next is, suppose if you cannot ventilate, then you have to use oropharyngeal airway or nasopharyngeal airway. Sometimes we have to use a two-hand jaw thrust to maintain the airway, and at the last resort, we have to use a LMA. On the right side of the screen, cannot ventilate cases, then you have to do a direct laryngoscopy with one chance. Only one chance you have to do a direct laryngoscopy. If that is not possible to visualize the glottis, then we have to do a rigid bronchoscopy, either a standby ENT specialist or a LMA. If you cannot ventilate and oxygenate, then the last resort is tracheostomy. It can be a needle tracheostomy or a surgical tracheostomy. Obviously, whenever the severe airway obstruction, the first thing what you do is call for help. Then you have to provide two-handed jaw thrust to maintain the airway and oxygenation. Insert a oral or a nasopharyngeal airway, and if possible, a laryngeal mask airway to maintain oxygenation and ventilation. Do a laryngoscopy once. If not possible, then do a rigid bronchoscopy, and then last resort is tracheostomy. ECMO is the last resort. That is extracorporeal membrane oxygenation. What are the basic postoperative concerns? What you anticipate in these cases? The one and only thing is airway obstruction. Airway obstruction can be caused by all these 3-4 factors. One thing is any previous airway obstruction will obviously lead to a postoperative airway obstruction. The other thing what can happen is surgically induced airway edema, because as you know, any surgery on the airway can lead to tongue edema, some sort of palatal edema due to the mouth gag itself. So what we need to do, what the surgeon in fact has to do is release this mouth gag intermittently, maybe after half an hour or 1 hour, just release the mouth gag so that the edema is to some extent less. At the same time, because of chronic PSO, or because of sleep apnea, these patients are prone for opioid sensitivity. Chronic hypoxia can itself, associated with obstruction, can have negative pressure pulmonary edema and lead to collapse of these patients. So these things should be kept in mind in the perioperative period, or in fact preoperative period, that airway obstruction can happen in the postoperative period as well. What are the preventive measures? As I told you, mouth retractor, NP and nasopharyngeal airways can be placed before extubation. So under visualization, after the surgery is over, you insert the nasopharyngeal airway just at the junction of the epiglottis and the vocal cords, so that the proper passage is maintained. Then these patients should also be always extubated awake, and analgesics should be provided with non-opioid analgesics, because opioids can themselves cause significant respiratory depression and obstruction. So to conclude, perioperative care of the neonate and infant with PRS involves input from many specialists, which are in the team now. The primary concern is upper airway obstruction, which can lead to significant respiratory distress and also feeding difficulty leading to failure to thrive. Patients with mild airway obstruction can be managed conservatively. Moderate or severe obstruction required invasive interventions such as gastrostomy tube placement, TLA, MDO, and tracheostomy. Selecting the most appropriate surgical intervention continues to be dependent on the culture and the expertise of the medical center at your place. These are my references. Thank you.
Thank you, Mane sir. We'll get back with some questions and with you very soon. May now request Kate, Miss Kate, to take over the presentation. Miss Kate is a consultant pediatric otorhinolaryngologist, head and neck surgeon, Birmingham Children's Hospital, UK. And she has done extensive work in the field of pediatric otolaryngology. And I'm sure she will enlighten us with the ENT perspective or otolaryngologist perspective in managing these patients, and the UK perspective as well. Because, you know, so Kate, the show is yours. Welcome on board.
Okay, thank you very much. Can you hear me nicely?
Yeah, perfectly all right, perfectly well. Perfectly.
Excellent. The technology is always a challenge.
Yes, to start with, yes. But once it goes, it takes us from across seven seas. It's easy to listen to people.
Yes, well, good evening to India. It's just lunchtime here in the UK. And thank you very much for the invitation to speak today. I'm thrilled to join you all. And I really love this really multidisciplinary meeting. I think it's absolutely perfect for this topic. And I hope I can add some useful notes from an ENT perspective. So as you say, I'm based in the UK at the moment, although I've worked in a few different countries, including South Africa. So quite a few different resource settings when thinking about airway care. At the moment, I work at Birmingham Children's Hospital, and this is really in the middle of England. It is a tertiary and a quaternary hospital, and it serves quite a few million patients. We have at our hospital over 500,000 patient visits a year. And as you can see in the picture on the left, the hospital was founded in 1862, before Pierre Robin even described his sequence. As you can see on the right here, we do have some new buildings. It's not all Victorian architecture. And we're lucky in our centre to really concentrate babies with complex airway problems and have the multidisciplinary teams that everyone agrees are so very much needed. Okay. So what I'd like to cover in this time, and it's not a lot of time, I hope I can keep to it, is to generally give an overview, which I think we've already had very nicely, and then really concentrating on the airway. And from my perspective is there a problem first? We're looking at such a spectrum of airway disease, but what exactly is the problem? Is there a problem? How bad is it? And how can I assess it in an emergency setting and in a planned and an elective setting? And if we need to secure the airway, what can ENT contribute? And although I hope never to get to that point, you know, my role often comes in the part of a tracheostomy. And I could talk about tracheostomy for, about 2 days. So I'll try and cover it in less than 20 minutes, some real highlights, and then maybe we can cover more in the panel discussion later. Okay. So this has been very well covered. Okay. But I suppose my point in highlighting what we have in a sequence is it isolated Robin sequence? Is it cleft or non-cleft? But crucially, is it associated with other abnormalities? Is the child syndromic? Because this will totally alter and influence the behavior of the airway. Something like a velocardiofacial syndrome or 22q11 deletion might have an associated laryngeal abnormality. So it really influences the chances of having a more significant airway problem. And it might be a syndrome that has features of Robin complex. So all of these things with glossoptosis, airway obstruction, and a small jaw, but they haven't occurred in a sequence because of a small jaw. So looking at why it's happened is really important, because one child is certainly not the same as another child with Robin sequence. And as well emphasized, the multidisciplinary management is absolutely key. No one specialty can look after these children optimally. And this is a short list, if you like. It's certainly not in order of any hierarchy, and there's probably some specialties missing. But this highlights where these children really need to be cared for if they've got a significant problem. We need to have specialists in neonatology, pediatrics, and aesthetics. I rely heavily on my respiratory medicine colleagues. And when it comes to surgery, that very much depends on the surgical roles in each centre or in each country. Sometimes it's more plastic surgeons that look after cleft patients, maxillofacial, craniofacial, have different roles depending on the centre and on the region. But we need all our allied health professionals as well. You know, I wouldn't dream of thinking of how to give a child or advise on nutrition or best feeding on my own. And then looking at the workup of the whole child and looking at the other associated problems, we might need the genetics, eye and ear care, as well as all of the support services that hopefully exist in the community. And again, that's very much resource and centre dependent. So coming back to the ENT role, principally it's airway. Things like the care of the ears mustn't be forgotten, but they come much further down the line in a child that might have ear problems because of a cleft palate. And again, we might be useful in terms of advising about feeding, but ideally we've got some specialists in feeding to help us with that. And why does the airway matter? Okay, well, apart from causing feeding difficulties, so the baby cannot coordinate their suck-swallow reflex, they're likely to aspirate and then develop lung problems. And if they're chronically aspirating, they feel like they're being drowned, they will stop feeding orally, they'll become orally aversive. And then if they have a bad chest through chronic aspiration, any challenge they have, any anaesthetic becomes even more risky. So we want to stop them aspirating and look after feeding from day one. These children need to grow if they have the potential of catch-up growth for their jaw. So if they can't feed well and if they're burning all their calories on trying to breathe and trying to survive, they might have growth failure. They might fail to thrive. If they have significant sleep apnea, we know that that causes developmental delay. They might develop other problems to do with their craniofacial shape. Reflux is more likely if you're in a chronic airway obstructive state with a lot of negative intrathoracic pressure. And again, that will make the whole cycle of airway problems worse if a baby's refluxing. And of course, this has been well covered. If you're retaining carbon dioxide, right heart failure and death can result. So in very poorly resourced settings, a baby with severe Pierre-Robin sequence, this could be a death sentence. So in some ways, I feel very lucky where we are in the UK in terms of the services that we can offer. And we have to look at what might be needed. A mild case might need very little intervention. We've heard very nicely from Dr. Badankar and Dr. Mane about what you might do with a mild case, thinking about postural management. And the main challenges a baby has is they've got to be able to feed. That's probably the most energetic thing they've got to do. So they might need postural management, particularly during their feeding, or particularly when they're asleep, when their tone is generally lower. We think of all airway problems to do with tone or worse when babies are asleep. The other end of the spectrum, these babies may need airway support very early on. The very worst can have a problem in the delivery room, as we've heard, but often it takes a few hours for that baby to really acclimatise, to start to work a little bit harder, and for the airway problem to get even worse. So the most severe cases often present in the first week, and they won't be able to safely feed orally, as I said. Now, I'm going to talk principally about tracheostomy, but I don't want to give the impression that we do it often for these babies, because we don't. I think the multidisciplinary care and the conservative measures and the other airway adjuncts, such as nasopharyngeal airways, mean that we very rarely need to do a tracheostomy for babies with Raban sequence. However, as we've heard, you've got to anticipate that this will be a difficult airway. The anatomy is altered. Your line of direct sight to get to the glottis and secure an airway might not be possible. And there's two situations. Ideally, you want to be making these assessments in a calm daytime setting in the right place with the right services, an elective situation. However, if you're in an emergency airway situation, there also needs to be a careful plan there. Okay. And we know in babies with Raban sequence, we've got at least one level of obstruction in the oropharynx and probably the hypopharynx as well. But are there other levels of obstruction? Could there be a glottic level obstruction, say with a laryngeal web? Or could there be a subglottic obstruction? Is there a congenital subglottic stenosis? Or through intubation, has this baby developed an acquired airway problem, which is often the case? If these babies are of any age as well, they might have an infection, an inflammatory obstruction. So, for example, if you have a baby who has laryngotracheal bronchitis, otherwise known as croup, as well as Raban sequence, you've got two levels to give you a lot of trouble. So that's when the airway obstruction and the management can be even more challenging. So what would be my tips in terms of looking at the airway and the assessment? Well, you want to be, as with most things, in the right place at the right time. If we had a child born with Raban sequence in a smaller hospital, they would be transferred to our children's hospital with an intensive care capability ambulance, so that we can manage them with us, with the right team, and with the right equipment as well. We find that's a much better situation than individual people going to a smaller hospital to try and deliver care. Okay. So centralizing these patients is really important, especially when they don't happen very often. We need to build our experience, and that's why doing something of low incidence in high volume in a concentrated way is very useful. And when the child arrives, I want to see them awake and in the ward, hopefully, or in the intensive care unit. I shouldn't meet them for the first time in the operating theatre. And as we've heard with the bedside assessment, you really want to look very carefully at the baby from all angles. You know, how small is the jaw? What's happening with the positioning, as Dr. Mane very well said. And for ENTs, you know, we very much like doing flexible awake endoscopy. And as long as that can be achieved safely in a ward or intensive care setting, we might get a really good dynamic, awake, real life view of what's happening with this airway. We'll get an idea of the degree of glossoptosis, seeing it from the inside. And we might also be able to check the glottis. Of course, that doesn't give us a view of below the vocal cords, but it's quite useful for everything above the vocal cords. And it's a real life situation, as I said, with a child that's awake. When it comes to the operating theatre, even within a children's hospital, we would like to think that we're using the most experienced anaesthetists to deal with a difficult airway. And not just the anaesthetist, the entire theatre team need to be prepared for this. So for any child, we would do a team briefing and advanced planning, because there needs to be a plan A, B, C, D, and so on. And I won't pretend to cover the anesthesia. It's not my field of expertise. But I think something that's already been mentioned, and I would agree completely, is that keeping these babies maintaining their own airway with our help is the best policy to start with. So spontaneous breathing is really useful, and hopefully we can maintain that all the way through. And ideally, when we're trying to do an airway evaluation, we want it to be a tubeless anaesthetic. We want to be able to look at from the top to the bottom of the airway to get all the information to help the professionals involved. And if we need to, introduce an endotracheal tube for stabilization. So preparation is key. This may come from an airway trolley and from the theatre equipment as well. As we've heard, a range of laryngoscopes. We have to think about rigid options, which is often the domain of ENT, or the flexible options as well. If we can't get a direct line of sight, we need something that can work around a corner. And I would agree completely with my colleagues, a laryngeal mask airway is a very useful adjunct. This might be used for transfer between centres or as something to buy time whilst you make other plans, going down the ladder of plan A, B, C, and so on. So what might we use for airway access? Well, ENTs like anaesthetists will use the laryngoscopes. And I hope you can see my cursor here on the bottom left. A straight blade, a Miller blade type laryngoscope is often our first laryngoscope for a neonate. However, in a child that has micrognathia, this may not be so useful. So using a curved blade, such as this Macintosh blade, coming from a far right paraglossal approach, I would agree with my colleague, that can often help. It does decrease the distance to the glottis, but also it might help you get that straight line that you might need to access the glottis. We have other laryngoscopes within the theatre equipment on the top right here. These are called Parsons laryngoscopes, and they're similar to a Miller blade. In children with craniofacial abnormalities, looking around the corner, a video laryngoscope such as this glide scope in the bottom right have really, really helped us in the last few decades in terms of revolutionizing how we can visualize and access the airway. And hopefully when we come to the theatre setting, this is with my previous colleague at Great Ormond Street Hospital, this is Mr. David Albert. We would love to be looking in a gentle fashion with the laryngoscope and a Hopkins rod rigid endoscope here and getting a lovely grade 1 view of the airway. However, this is not likely to be a child with Raban sequence given the ease of laryngoscopy. But as you can see in this theatre setup, the anaesthetist is close by on the left here. He is watching a separate screen so they can see exactly what is happening at all times, and you can communicate very, very closely. You can see the tip of the nasopharyngeal airway here coming from the soft palate, and that's being used to deliver oxygen. It can be used to deliver a volatile agent as well. So this is an ideal world, a very easy laryngoscopy, and then we can proceed to evaluate below the glottis. However, this wouldn't tend to be the case in a child with Raban sequence. As you can see on the picture on the right here, this is a much more difficult view. Again, we've got the nasopharyngeal airway using as part of the intraoperative anesthesia, but we haven't got a view of the true vocal cords at all. We've got a view of the arytenoids here at the back. And I'd like to come on to a case that I evaluated recently. This is a child with non-cleft Raban sequence who presented in the first week of life with severe airway obstruction. And top left here, you can see the blade of the laryngoscope is very much on the tongue base. This child does not have a vallecula to speak of. The tongue base is right back with the epiglottis, and that's the very best possible view I could get with any laryngoscope. And you can see that actually the whole larynx is being lifted forward with the effort of trying to view. So the nasogastric tube or orogastric tube is clearly seen because the whole of the larynx is being lifted forward from the hypopharynx here to get the best view. But you can just make out the arytenoids, but you can't see the glottis otherwise. Coming in with an endoscope, in an ideal world, you get a top to bottom evaluation. And here is the glottic view, the third view for subglottis to trachea, and from the bottom of the trachea to evaluate the carina as well. And we really want to see, is there a second airway lesion? Is there even a third airway lesion? It's very easy to concentrate on the top when there's been a difficulty in accessing the glottis, but we mustn't miss, say, laryngomalacia, a laryngeal web, a vocal cord paresis, or some distal problem that will influence our management. Okay. And external pressure, what I mean by that is an anaesthetist or an assistant pressing on the outside of the neck to give cricoid pressure, or what we call BURP, burp, backwards, upwards, right pressure, might assist in getting a view of these cords with a rigid endoscope. Looking further down, I might use head rotation to visualize the bronchi as well. But all of the time, I'm communicating with the anaesthetist. And if we're having difficulty, we might come out, go back to some bag mask ventilation, go back to a laryngeal mask airway, change plan. So we've got intense monitoring, intense communication all the way through. These are some tools that I might use if I needed to intubate quickly. At the top here, you can see an endotracheal tube that's mounted over a rigid endoscope called a Hopkins rod. So you can simultaneously visualize and then intubate. So it works as a bougie. But again, that depends on being able to get a direct line of access, a straight line to the glottis. And you might be able to achieve that using a right paraglottal approach, using some laryngeal pressure. As mentioned, rigid bronchoscopy is something that we often use, and then this can be used for ventilation as well. And if we have no other options, you could keep this in place whilst a tracheostomy is done. Similarly, you can even do a tracheostomy with a laryngeal mask airway in place. Not ideal, but it's possible. So these really are where ENT can come into use. One other last adjunct I'd like to mention alongside the use of a laryngoscope, a video laryngoscope, such as this glide scope, is using this alongside a flexible intubating laryngoscope. And I think this is what Dr. Mane was referring to as well. So sometimes if you can't visualize where you need to go, it's quite difficult. So you need the optimum laryngoscopy as well as the optimum intubation technique. So in craniofacial patients, such as those with Raban sequence, sometimes we use a video laryngoscope as well as an intubating fibroscope in those that need to have around the corner access. And these are patients that I will not be able to evaluate with my typical tools. We'd be using flexible bronchoscopy to do a distal airway assessment. And that's where we might work with colleagues in pulmonology as well. So moving on to airway intervention, and by airway intervention, I mean all sorts of anything invasive. So a nasopharyngeal airway or a pharyngeal airway or a surgical airway. So we need to have an idea of which patients might require this intervention. And again, through the spectrum. And if there's an intervention required, well, what's the best procedure that we can do? And it depends on all of these factors. Obviously, there's the factors of the disease. Is it mild, moderate, severe? How old is the child in the patient factors? And particularly in the healthcare system factors. This might be the preferences or the customs of what's done. So some centres do a lot more tracheostomies than others. Some do a lot more nasopharyngeal airways. And it varies according to the expertise and the practice. And having a tracheostomy in one country may have a lot more influence, say, than in another country. So the aftercare and the implications for the child and the family could be quite different. And I think in the literature, we see a wide variation in practice, not only within countries, but also internationally. So there's no one recipe for these patients. It's rather a menu that we have to choose from. This is a protocol from my centre, and I won't go through it. It's a lot to read. But this is a typical flow chart of a child with Raban sequence that has a cleft palate. They'd be referred to our cleft team. We're lucky that we have nurse specialists that will meet the family before a child is even born if we know that the child has a cleft palate. So they can be prepared for the airway potential concerns or the feeding concerns and what might be needed for the child in the future. As you can see circled, I'd like to follow the path of airway concerns. And this might be from mild in group 1 up to severe in group 3. And for the mildest, they might not need to be transferred to a major centre. Just positioning and monitoring, assuring that they're stable, might be sufficient. However, they might need feeding intervention, such as tube feeding, or in the case of group 3, they need further assessment and they come across to a specialist unit to really look at their airway in detail. These patients may well have a nasopharyngeal airway inserted as a trial, as their first step. We'd be doing lots of other things at the same time as a team, thinking about minimizing reflux with positioning of the cot, elevating the head. If they are feeding, thickening the feeds, all these measures to improve reflux, and really looking at how they are growing. So we'd be weighing them daily or every other day. And this gives us an idea of how they are coping. If they can grow and have airway safety, they may not need further intervention. So I think a patient approach is really important and a very careful assessment. And if the child can have stability with the nasopharyngeal airway, we're able to look after this at home. We train the parents and we have community nursing that can support them. So a long-term nasopharyngeal airway is often a really good option in our setting. But I wouldn't pretend that that's a good option in every setting. But often, if it buys time, it saves the child major surgery. They've had airway safety for the time that they've needed it. And often by about 6 months, it can be removed through monitoring and decision making. However, if the nasopharyngeal airway is not doing enough, that's where we're brought in as ENT. Before this point, these patients will be with the neonatal team and often the cleft team if they have a cleft palate. As ENT, then we'll look at the airway and participate in the team decision making. And when we talk about multidisciplinary management, it's formal meetings from early on. And these are meetings that we have as a team. And then we bring the family in as the second part of the meeting. So the family are also part of our team. So they really are involved, they're informed, and they have hopefully a good idea of what the options are. So we make the decisions with them, not for them. So a snapshot of the UK experience comes from my former centre of Great Ormond Street Hospital in London. And this is an 11-year experience, a sample of over 100 patients with Raban sequence. And this gives an idea of the spread of what we might do. About a quarter managed conservatively, 60% with a nasopharyngeal airway, and only 14% of this series having a tracheostomy. I won't talk on a nasopharyngeal airway in much more detail, lack of time, and there are other people to cover this, but as I want to emphasize, it can be long-term. These are patients that it can work very well for in my experience, and it certainly can avoid a tracheostomy. Although I like doing tracheostomies, they should be avoided at all costs. So coming on to tracheostomies here, they're, as I said, a last resort, and we're much more likely to do them in children that have other problems other than the pure Raban sequence. If they have a syndrome, a comorbidity, particularly things that give them other levels of obstruction, put them in intensive care for a long time, or if they're hypertonic, those are the children that are most likely to end up with a tracheostomy, those 14%. And we might be doing it in isolation, buying time for growth, or it might be a covering procedure for expanding the airway. And tracheostomy, the most important thing is at all stages within the surgery and in the aftercare is we make it as safe as possible. The downside of the tracheostomy is in the morbidity and mortality that's associated with it. And this really can be minimized. Can't be excluded completely, but it certainly can be minimized. Some highlights in terms of the preoperative preparation. We want to be using neonatal tubes for these patients so that they have a shorter inner cannula that doesn't go too far down the trachea and risk intubation of the right main bronchus. And through the range of tubes that hopefully are available, having a tube with a straight neck flange like this one are better for neonates, often because of their neck shape. We want to be using the right size tube, and you can use a chart for this, or there are free apps such as the Cincinnati Airway Card, which give you the airway sizes and the tracheostomy tube sizes for each age. And that's a guide. Of course, it's got to be tailored to each patient. And what type of tube do we need to use in terms of cuffed or uncuffed tube? In babies, we should always be using an uncuffed tube unless we've got a good reason. Cuffs can come with trouble in terms of needing extra care, causing more interference with swallowing. They give a more critical situation when a tube is blocked. However, if you do need more airway protection from aspiration or a cuff needed for effective ventilation, then there are cuff tube options. We want to check the tube very carefully before a tracheostomy is done and make sure that we've got the suction exactly right. This is an example of the airway chart that I use at my centre, and we have a guide for endotracheal tube, bronchoscope sizes, and all the different tracheostomy tubes that we might have in use. And this is quite useful for comparing lengths from neonatal to paediatric and so on. One thing I'd like to highlight is this type of tube that has an external flexible outer part. This, for example, is a bivona FlexDen tube. And in a child that has a very small jaw, the tracheostomy outer part can very much be sitting on their chin and cause a lot of pressure problems or be covered. So a tube that has a flexible, extendable aspect is particularly useful in these children. When it comes to then getting into the operating theatre and preparing for the tracheostomy, as I said, it's ideal that the patient is intubated. However, if this isn't possible, we can do it with an anaesthetist holding a mask. We can do it with a laryngeal mask airway or over a rigid bronchoscope. But having an endotracheal tube gives safety, and it also gives us a trachea that's much more easily palpable. A neonate's trachea is barely palpable, and when you have a tube in place, it really makes it a little bit more firm and easier to do a tracheostomy. So certainly that's first prize. The patient needs to be positioned in extension, but not overextended. Otherwise, the trachea will pull too much out of the thorax and you'll end up with the tracheostomy going in too low. So you want it just right, not too high, not too low. And often you need a good head support for the child, a newborn that has a big occiput. So a combination of padding between the shoulders and the head to give a nice stable support. And we tend to use a chin strap to get that degree of extension and the chin out of the way, but caution against hyperextension. Again, this can be looked at in a surgical atlas, and I'll just go through some highlights on these slides. I'm cautious of time. Okay. But this should be calm, careful surgery by someone experienced in neonatal difficult tracheostomy. I would always like to use magnification with wearing loops because this is very small anatomy and very small margins for error between the trachea, what's happening lower down, the pleura, and the esophagus behind. That's where your risks lie. And it's a small incision because the skin will stretch very easily between the cricoid and the sternal notch. You can make a vertical incision, and particularly if you're in an emergency, that might be the best thing to do. And as you can see in the bottom right, dissecting to the trachea, clearing any fat out of the way, and taking great care to stay in the midline. Here we are, this is the head and towards the feet of the patient, and we're looking at the strap muscles here separated and a clear midline, and continuously checking that you're in the midline by careful palpation. We might need to divide the thyroidisthmus, and in a baby, that's easy to do with bipolar. You don't really need to clamp it and tie it, but you certainly don't want it to be in the way. Then how else can we make this procedure more safe in the post-operative period? Well, we can use stay sutures. And here you can see the sutures placed on left and right in the trachea of a newborn. You can see the tracheal rings very clearly. And these are secure, hopefully, sutures that if a child needs a tube to be replaced, it will help you replace that tube in the first post-operative week. So you can see this is nice and dry. We're preparing to make a tracheal incision, and the stay sutures have been placed. You want to incise as few rings as possible. And one thing that I like to do, and is common practice here, is something called maturation sutures. These are highlighted with the white arrows here. These are stitches with an absorbable suture that goes from the skin down to the trachea that create a closed opening, if you like, a stable opening a closed space between the skin and the trachea. So even if the tube is not in place, you've got a stable opening. This will heal more quickly as well and be safer in the first post-operative weeks. Once those are placed, the endotracheal tube can be retracted, communicating with the anaesthetist, not taken out completely, but just retracted enough that you can put the tracheostomy tube in. When you've got adequate ventilation, then the endotracheal tube can be removed completely. So that's another nice safety measure to use. This is just to demonstrate again. Here we have the stay sutures, either side of the tracheal opening, and the maturation sutures, which then go from skin down to trachea. Once the tube is placed, these stay sutures, the blue, non-absorbable, can be clearly marked for right and left. You don't want to mix them up and cross them over. And we generally have those in place for a week. The complications of neonatal tracheostomy are particularly what make people worry about it. And I think these are well known. I won't go through them in detail. And of course, there are the intraoperative concerns about damage to surrounding structures, pneumothorax and what have you. But post-operatively, these two in red really are the most important. Children with tracheostomies have problems and have arrest and demise because the tubes come out or the tubes block. And the smaller the tube, the more likely you are to have a problem. So these are the things that really matter. So in fact, the surgery might be one of the simplest parts of it. The anaesthetic to have the surgery might be harder, and it's the post-operative care that really matters, both in and out of hospital. So optimal aftercare really is important. And this is more of a consideration than the feasibility of the surgery in some ways. So depending on the setting might influence where you might care for the child, but there should be an emergency algorithm by the child's bedside. And ideally, this helps guide everybody looking after the child. You might need an equipment box. This is useful for having everything with the child at all times, to replace the tube and to suction and what have you. And the training of the staff and the family is really, really important. This is well covered in the literature, but can't be overemphasized. This is a sample of a UK-based emergency tracheostomy algorithm, and it's available online. But this is what we would have at the bed of each patient with a tracheostomy. So it's a guide for anybody who attends that child as to what they might need to do. And you can also tailor it to the child. So if there was a particularly difficult airway, we'd have additional notes with it. Depending on the setup, we would aim to have a child with a tracheostomy discharged from hospital within about 6 to 8 weeks, but that depends on the training of the parents, which is done in detail. Obviously, if the child requires ventilation, that is much more complicated. But a tracheostomy alone, we hope to train the parents from early on, have them independent, and with the support of community staff. Hopefully a tracheostomy doesn't mean that they have to stay in hospital for a long, long time. Okay, so to bring it all together, with Raban sequence, it really is a multidisciplinary approach, and it's completely tailored to each individual child. If we work together in high volume centres, we get more experience with these children and hopefully get better at what we do. But this airway management is challenging. You cannot do the same thing for every child, and there might be different steps that are needed. But the main thing is to ensure the safety of the airway, both in and out of hospital, and to decide together what's the best way to have that airway safety. And if the child's airway is adequate, they might be able to feed, they might be able to grow, and that will guide what other things might be needed. And without focusing on the airway too much, we mustn't forget from an ENT point of view, there are other manifestations that we might need to look at that other than the airway, particularly the ears in cleft palate patients. And I look forward to the panel discussion. I hope that's been useful, and I hope that I haven't been talking for too long. Thank you very much.
No, absolutely not. Absolutely not. Thank you so much, Ms.
Thank
Kate,
you.
for sharing your
Thank you,
protocol and UK experiences with us.
My pleasure.
I think we can take the questions during the panel discussion. Now, moving
Yes,
ahead,
yes.
I would like to invite Professor Alexander Hempris, Professor Emeritus, Department of Maxillofacial and Plastic Surgery at University of Leipzig, Germany. He'll be talking on conservative care for airway management in Pierre-Robin sequence. Over to you, Professor.
So now you can understand me now? Hello?
Yes, sir.
Okay. My pictures are well to be seen as well. Just a second.
Yes, yes.
So,
It's all
okay.
perfectly all right.
Okay, thank you very much. Well, again, I'd like to really thank Goslar Reddy for inviting me. We have known each other for now exactly 20 years when we first met at a Zurich Cleft meeting. And so I'm very thankful for him adding me to this wonderful set of speakers. Well, we do not see so many PRS children in my unit in Leipzig, but I have to tell you about the experiences of the Tübingen Hospital in Germany too, who really have established a wonderful way of dealing with these children. About the Pierre-Robin sequence, many things have already been said. I don't have to repeat them. So what kind of non-surgical, or I would say minimal invasive treatment options do we have? First of all, the prone position. We have heard that this is a very good option for lesser problems. Then the nasopharyngeal intubation has also been talked about, and CPAP ventilation. I will give a small comment on that. And what we haven't seen yet are the orthopedic plates. There are two ways of doing them, conventional ones and those with stimulators. And under number 5, I have a very old method, but which can be modernized and really being useful. It's a roll extension to foster mandibular growth, because mandibular growth is one thing which really is lacking in these children. And if you pull on the mandible very gently with 70 to 100 grams a day, you give a growth stimulus to the mandibular angle and the mandibular necks. And that will help. And finally, I will tell you about the Tübingen palatal plates with the pre-epiglottic baton to push forward the tongue. We start with a prone position. Well, this is a wonderful way of doing it. And we have to keep in mind, though, that prone position is also responsible for sudden infant death syndrome. So you can do it, and it's a good way of doing it, but be careful and have a monitor always adjusted. This is important, otherwise you may have a problem with these children. Something happens to my, I'm sorry. Okay, now we have a child shortly after birth, a short mandible, this one with a palatal cleft and a mild glossoptosis. Breathing was possible in a prone position. Nasopharyngeal intubation. Ms. Stevenson really gave a very good outlook on this method. Well, the things I know of are hypersalivation, and if it's a long-term procedure, there may be problems, especially with the wrong position, the loss of this nasopharyngeal tube, and there can be some dangers coming from this. Here you see this child with a nasopharyngeal tube, which is happy, and we don't really have so much problems, but you have to make sure the position is taken. And I've seen at Ms. Stevenson's presentation a way good of holding it. Now, if you have the CPAP ventilation, which is a way of securing breathing in early times for the child, but on the long run, especially in cleft cases, it's very difficult to produce a mask that really fits to the mid-face. And moreover, if you exert pressure to the mid-face by this mask for a long time, then you risk of having a mid-facial retrusion and a development problem of the mid-face because the bone is just too weak for this. Okay, now we come to the orthopedic plates. Well, let's see, I hope my little, movie works. Now, this is our orthodontist who really has produced one of those hard plates, passive plates. You see him now inserting it. And the thing is, there are no pastes used or holding it, but the little child will learn keeping it up with a tongue, and eventually it will stay on place. And the object is to keep the tongue out of the cleft and bring the tongue more forward in a forward movement. So we can see this child here, that the cleft palate can develop further on. And this is not the only child I've seen. Now you see here where the cleft palate has really narrowed after about half a year or a year of this conventional plate therapy and muscle stimulation after Castillo-Morales, which has to be done by a well-trained speech pathologist. We saw this substantial narrowing of the cleft, and at the age of 11 months, I would usually operate such a cleft palate using, of course, a complete muscle rearrangement, which was described by Queens and in more modern times by the British colleague in London. I have to talk about his name later. You have seen the conventional plate, and if we really want to give a bigger stimulus to the tongue to come forward, we can add stimulating elements, as you can see them here on this little plate. You see them here. Just remember, when you eat an apple and you have a small piece of this apple between your teeth, then you really always go forward with your tongue to try to get that out. And this is the same way these little stimulating elements are working. So they really bring the tongue forward and foster mandibular growth. Now we talk about this old method of roll extension to foster mandibular growth. Well, there is a small operation in general anesthesia, and we need the patient for about 3 weeks, 4 weeks, sometimes 2 weeks are enough to really see the progress in mandibular growth. What do? We make a small mandibular plate with an adjustable loop, which can come up and go around the lip, the lower lip, in the front of the attachment, in the front for the attachment of the weight. And you note here these 2 small loops on each side for the circummandibular wires, which we need to fix this little plate on the mandible. Here, this is a very old picture from 1985. You go around with an awl and come back and bring this wire into the mouth, where you can strap it around this little plate. And I think I've seen Tony Marcus, and maybe there are some other older British colleagues who really have done this a lot. And when we had the British colleagues in Münster in my early times in the 1980s, they taught me how to do circummandibular wiring. It's very little problem. It's a very little operation, very small operation, which can be easily done. And in my hands, I've never seen any bleeding problem when you really stay close to the mandible, even in very small children. And here you see the connector between the mini plate, and here now the string which will bear the weight for this pulling of the mandible. You see this also here, everything is in place, and we are about to connect this one with a weight of about 70 to 100 grams over this roll extension. That's why it's called like this. And the baby will need a mild sedation in the first 2 to 3 days, and you can change from the supine to the lateral position after 2 to 3 hours during the day. And in my experience, I've seen the first ones for 30 years ago or 35 years ago. We never had any problem with these children. They tolerated this quite well. And if you wanted to feed them, you just unhook them from the weight, and this is possible then. What we found in the very beginning, we thought it would need 6 weeks, and we went down even more, down to almost 2 weeks, depending on the severity of the mandibular underdevelopment. Usually after 2 to 4 weeks, you have brought the mandible forward so much that the tongue won't fall back into the airway. And now we come to this newest tool we have, the so-called Tübingen palatal plate with a pre-epiglottic baton. What has to be said, it needs to be inserted under endoscopic control. You definitely need a team approach with an orthodontist, a pediatrician, neonatologist, and maxillofacial surgeon and orthodontist to get all the requirements done which you need to safely put it into the patient. Now let's look at it. This Tübingen palatal plate is just a simple palatal plate, but with the addition of a wire on the dorsal part of it. And this wire is usually 3 centimeters long. One could also say this wire should be about as long as the palate. And when you insert this plate under endoscopic control, you can adjust the correct position. You can adjust the correct position by bringing it forward or backward to push the tongue forward as much as needed. Sometimes it's too much and the patient doesn't, the little baby doesn't tolerate it, then you have to go back a little bit. But once you have found this correct position, then the position will be fixed by adding self-curing acrylic. Now, what about these 2 wire bows here? You can imagine when you put a plate in like this and the tongue pushes back because it wants to get back, then the whole plate tends to fall down in the frontal part. And here you see the conventional impression taken by an orthodontist. More recently, we use scans of the maxilla. And we have another tubular form of the baton with a tube to increase the posterior airway. And then under endoscopic assistance, you insert the plate. Here you see now this the lower end of the baton, and that is still too far approximately on the tongue. It doesn't prevent the tongue from falling back. Here you see the prolapse of the cartilages and some edema. Here the larynx in the very depth, supraglottal edema, but here you see again this baton is too short. See the ventral tube on the right, and now we have added and lengthened this baton, and now it's in the ideal position in the vallecula epiglottica, and this child here really had a very minute epiglottis, but it's open and the child can breathe very well. Here you see the plate inserted, but not yet activated. As I said, these loops may come downward forward if the tongue really exerts pressure on the baton. And in order to counteract this, you have to tape these two loops with some tapes to the face of the patient. And it's really good. It works. It has worked for weeks and no problem ever arose. Here you see this child from the lateral sides. And here you have to see to it that the metal bows do not disturb the lip. Can be done. And you also have to see to it that the metal doesn't really interfere with the tongue, but it's also possible. And now you see this boy after 6 years and 3 months. I operated the cleft palate with intravelar veloplasty at the age of 11 months. And so far, except for the early orthodontic procedures after birth, he did not receive any treatment yet. And this is the result of the palatal closure. His speech is fine. And even if he received some grommets in the beginning, now his hearing is also fine. And you see a normal occlusion. And this is now the boy at age 6 years and 3 months, where we can still expect him to grow well. So the experience at the University Hospital of Leipzig within 11 years, we had 30 patients with PIS. 10 mild forms could be treated with orthodontic plates and Castillo-Morales muscle stimulations. And in 20 more severe airway problems, initially we did 15 tubing plates. 2 of them had to switch to the roll extension therapy because the parents wouldn't comply. They said, oh, we can't handle this. We are not able to put the plate in. And they weren't able to take the child home because you need to keep this tubing and plate in for up to 3 months to really make it successful. But they couldn't, so we said, okay, then we can offer you this roll extension therapy. And I must admit, in the time before 2008, we did roll extensions rather regularly. After 2008, we switched more and more to the tubing and plates. In 2 cases, we did have to do tracheotomies due to multiple deformations and extreme small deformed mandibles. And I do thank Ms. Stevenson again for really pointing out that the tracheotomy is only a procedure in such special cases. We saw good results in the long run as for the airway, but also for facial development. Under constant jaw orthopedic and orthodontic guidance, no orthodontic surgery had to be performed in the non-syndromic cases. And now I will want to just refer to you the results at the largest center for PIS patients in Germany at the hospital at Tübingen. They had 443 cases, 129 of them syndromic, treated with the Tübingen pre-epiglottic baton plate in the last 20 years. and only 5% of the syndromic cases needed a tracheotomy. So that's quite a low number. Sleep studies, which they did, revealed an improvement of the median MRI from 13.8 per hour to 3.9 per hour after 48 hours already, and down to 1.7 per hour after 3 months. Mandibular catch-up growth may be induced by the tubular plate. The study is on the way, but the complete results have not been published yet. And fewer respiratory complications after palatal closure in TPP-treated patients were seen. The palatal closure could be done and no respiratory complications arose. And another wonderful study they did, they found that the intellectual development of PRS children having been treated with this special plate is comparable to healthy controls. And here you see the reference at the Journal of Craniomaxillofacial Surgery of the year 2019. There, all these results can really be seen. In conclusion, I would say when we take into account these good long-term results with the palatal plate, with the periphyllotic baton, not only in Tübingen, but also in many other centers in the world, other much more invasive methods of treatment like glossopexy and mandibular distractions seem to be an unnecessary harm to these small patients. I have listened to many American colleagues at different conferences who always use the fasted preferred mandibular distraction. I don't think it's necessary. You have problems with tooth buds, you have problems with the mandibular nerve, which are not necessary. And as we have already heard, and I can also say this, tracheotomies should be reserved to extreme cases of syndromic PRS. And the disadvantage of the TPP treatment is the need to assemble a multidisciplinary team of devoted specialists. This should be no problem, though, in well-organized cleft centers. Well, and with this picture of the new City Hall of Leipzig from 1905, I thank you very much for your kind attention.
Thank you. Thank you so much, Professor. Thank you so much for giving us an insight on the conservative management of airway in Pierre-Robin sequence cases. Thank you so much. Now, moving ahead, now I would like to invite Dr. Rakesh Ken. He is professor in the Department of Plastic Surgery at Safdarjung Hospital, Delhi. Sir will be talking on the topic of surgical management of Pierre-Robin sequence. Professor, if I can request you, if you can just stop sharing your screen. Thank you so much. Thank you. Over to you, Dr. Rakesh. Dr. Rakesh? Dr. Rakesh, you are not audible.
Hello.
Hello. Yes, sir. We can hear you now.
Hello, sir. Can you hear us?
Not visible. Not visible. Not. Hello, am I audible?
Yes, sir. You are audible, sir.
Thanks for the organizer for
Your volume is very low.
now. Hello.
Yes, sir.
Better,
You're
sir,
audible.
but
Okay.
Yes, sir.
Okay. So thanks to the organizer for giving me a chance to speak on this complicated topic. Okay,
Sir,
everyone,
can you keep
everything
the
is
mic closer to your mouth, sir? Can you keep
yeah,
it
yeah.
closer to your mouth?
Yes, 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 yes. Now it is better. Hello.
better, sir?
Yes,
Yes,
sir.
sir, better.
Okay. So to proceed with the surgical management of the period of next slide, please.
Dear Professor, I think your mic volume is low. Can you increase the volume of your mic?
Hello.
Yes, sir, you're audible now, sir.
Since I have increased it completely, is it audible now?
Keep
Sir,
the
it
mic
will
closer
be
to your mouth, sir.
Yes, it's very close to my mouth. Very close. Please move to the slide. Dr. Dasha, please.
sure, sir, sure.
So we have discussed a lot about the conservative management and the actual clinical problem associated with the period of the sequence. It's a very interesting to look the statement given by the syntax that the philosopher
Sir, your voice is really breaking.
the cause of much clear about the two terms hypognathia and the retrognathia is the behavior of the sequence. The hypognathia is the maybe hello. Hello, next slide please. Hello.
Sir, your voice is breaking.
So whenever we did the
Sir, we can't hear you.
hello. Hello. Hello.
Sir, you need. Yes, sir.
Is it audible now?
It
Hello.
is, sir, but it is very, very low, sir. It is very, very low volume.
Now, is it okay now?
Yes. Yeah. Now it's perfect, sir.
Hello. Hello.
Yeah. Now it's perfect.
Hello.
Now it's perfect, sir.
That's perfect. So it's without the earphone. Okay. So start with the airway obstruction. So one should be very much clear about the management of these patients. They should be thoroughly examined and they should be carefully evaluated for the problem. So we should look for the apart from the all other conditions which are discussed by the previous speakers, and it is very nicely covered by the Rajesh Mane, anesthetist, and the other speakers also. One should look for the spondyloepiphyseal dysplasia congenita. Other thing is the tracheomalacia. We should not forget about it. And one should know about the obtuse cranial base angle. And one should be keep in the mind the cause of the hypoxia may be the central cause due to cervical or the medullary compression. Next slide, please. It's reasonable to start with side lying position or the prone position to see if the obstruction is resolved. This is very much clear. So whenever the patient born with such type of the problem, we should give a trial for the conservative management, and the most of the patient may be treated by these methods, as these are discussed by the previous speaker. Fiber optic intubation is a good option, LMA, and then comes the tracheostomy and the dissection osteogenesis. So in the surgical option, you consider like the tracheostomy, dissection, osteogenesis, and tongue lip adhesives. Next slide, please. So the either you call it no, previous one. So either you call it the glossopexy or the tongue lip adhesion. It is in 1911. So about this procedure, throat and obstructing the airway, it is because of this fall of the tongue is developed the cyanosis. In such type of the patient, after evaluation, when you find out that the patient is not getting relief by the conservative management, you can opt for the glossopexy. Whenever we do the glossopexy, now it's need to keep throughout the year. At least it should be continue for a year. And when we plan to repair, and at the same time, patient should be evaluated respiratory obstruction, sinus, and G reflex also. Incidence of doing the glossopexy. Next slide, please. Now next is the tracheostomy. Next surgical procedure, tracheostomy, as it is mentioned by the previous speaker, so it's a last resort, as it is mentioned by when the other measures fail and the potential long-term morbidity and mortality. A complication as discussed by the previous speaker, like the mucus plug formation, stenosis, and other bleeding challenging doing the tracheostomy in the pediatric patients or the neonates. And it carries the emotional, financial, and the physical impact on the family. About 16% of the incidences of doing the tracheostomy in the PRA Robin sequence, and it should be reserved for the last resort, but cover procedure. Cover means sometimes when you are planning for the mandibular dissection or doing the mandibular dissection, at that time you maintain the airway by the tracheostomy. So other thing, third surgical option for the correction of this problem that comes is the mandibular dissection osteogenesis. So mandibular dissection osteogenesis is not immediate relief post-operatively or as a support. At that time, you need the post-operatively, patient should be intubated and airway then should be maintained. And dissection is normally start after 48 hours and give good analgesia, 0.5 millimeter per day. And we can use the unique planner or the multi-planner dissection. And there are definitely, whenever you do the surgical procedure in the neonates means in infancy, actually it requires, because of first of all, you give the trial of the conservative management. like nasopharyngeal airway, prone position, and tongue lip adhesions. So after that, when you decide for the mandibular distraction, there are multiple options are available. You can use the external distractor or the internal distractor. And there is a risk of the injury to the teeth bud as a complication and the injury to the inferior alveolar nerve. Next slide. So the decision about the mandibular distraction osteogenesis, as is mentioned by the previous speakers, we can follow the sum of the algorithm, or we have the sum of the scoring, or clinical evaluation of these patients. Like whenever you say, hello, whenever you say the patient is given a good conservative trial and the patient is not maintain the oxygen saturation and failure to thrive, and there is no increase in the weight, and there is a prominent GE reflex also. So we take in consideration of the five factor, and one of the score, one of the mark is given to each of these factors. So one is the gastroesophageal reflex, it carries 1. Second is the intubation preoperatively, it carries 1 mark, 1 score, and late operation, if it is done after the 2 week, it carries the 1. And if it's a low birth weight baby, less than 2.5 kg, it carries 1. And if it's a syndromic association of the PRS, then it's 1 mark. And if the score goes more than 3, then the chances of no benefit is 40%. And gastroesophageal reflex is concomitant airway anomalies, and concomitant airway anomalies, these two factors are very negative predictor of the success of MDO. So use the diagnostic imaging, laryngoscopy, bronchoscopy to decide about the MDO and your conservative trial. Next one. So even after, whenever you do the MDO or the mandibular distraction, it doesn't mean the patient in his childhood, when he will grow, the mandible will come in the normal size and it will relieve the airway. So favorable outcome is dependent on selecting the most appropriate intervention for the child, depending on their symptoms, examination findings, and the comorbidity. The care team and the family must be aware about success and limitation of the proposed treatment. This is very important. It doesn't mean that whenever you do the MDO or whenever you do the lip tongue adhesion, it will definitely correct the obstruction or the this problem. And one should be very much clear about the limitation of this treatment, and it should be thoroughly discussed with the parents of the child. Next slide. Even I have seen in these patient, one of the patient, even from the following from the neonate, who had the maxillomandibular synchondrosis. So had the same problem of the this hypoxia and small mandible retrognathia. So initially the conservative management was done, but it is observed that he was not able to, actually a female patient, she was not able to maintain the saturation and failure to thrive, and there was the positive G reflex. So the mandibular distraction was tried at the age of 5 or 6 months. It was done, but even when she was grown up, at that time also she had the problem, and the sleep study there was, it is found there is the obstruction in the upper airway. So you see in these scan pharynx is narrowed. Next slide, please. So mean to say, even if you do a good good surgical correction of these such type of the problem may not be relieved by the surgical intervention, and even if you do the good mandibular distraction or tongue lip adhesion, the problem may persist. And I want to share a very this experience that one of the patient of the PRS who who were required tracheostomy. The patient was on tracheostomy for a couple of years, and the ENT people were not able to remove the tracheostomy, because of whenever they tried to remove it, and patient start developing the this breathlessness and the hypoxia. So patient was remain on tracheostomy for the years even, and even we did the again mandibular lengthening in one case we tried even the bulk reduction of the tongue also, bulk reduction, but sometimes it works, and then there is a limitation of the surgical procedures. I think this is the last slide. Thank you. You can see in this scan, side scan also, you can see in this scan, the posterior passage was very much narrowed because of the glossoptosis, and that was, I want to show you. And you see how the mandible was this posterior passage, and the thank you.
Thank you, sir. Thank you, Dr. Rakesh.
Thank you. This is the end of the slide. Thank you, Dr. Abhilash.
Thank you, sir. Thank you so much, sir.
Hello.
Yes, sir, you're audible,
Hello.
sir. Thank you.
Hello.
Yes, sir, we can hear you, sir.
Thank you. Thank you.
Thank you, sir. Moving ahead now, I would like to invite Dr. Sharan Naidu. He is currently practicing as a specialist maxillofacial and oral surgeon at Mediclinic Midstream Hospital in Pretoria. He will be talking about surgical intervention for airway management, when and what. Over to you, sir. Dr. Sharan, can you please share your screen? Thank you, sir.
Hi there, can you hear me?
Yes, sir. Yes, sir. We can hear you.
Good evening, all. I'd like to thank the organizers for inviting me to give this talk. So my name is Sharan Naidu, and I am from Pretoria, South Africa. I am currently affiliated to the University of Pretoria. However, I do have a private practice at the Mediclinic Midstream Hospital, and you're all welcome to visit our sunny South Africa. It's usually a beautiful country, and welcome to make contact with me should you decide to visit. So, having taken up this invitation to give a talk, I was obviously expecting that there would be a tremendous amount of overlap of the modalities, and I'd like to congratulate the previous presenters on giving very comprehensive and sound information on this topic. So I actually messaged Dr. Goslar, and my intention would be just to give an overall view, although it would overlap as well, but I think it would benefit the residents that are listening on, just to cement the protocols that could be implemented. All that I could share that would be new would be my experiences at my unit. So having said that, I'd like to just introduce...
Excuse me, sir, if you can just do full screen mode, viewers mode.
Sorry?
Hello?
Yes?
Can you just presenter mode?
Okay. Is that fine? Is that fine?
Okay, sir, no problem. Please carry on, sir.
Is that fine?
No, it's not yet.
We can see two slides, sir.
Okay, let me just get this off. I apologize.
Just put the slideshow, it will be okay. Second on the right.
So on the bottom, yes.
Yes, okay.
Perfect, sir, perfect.
Let me just get this smaller. Okay. Okay, so having said that, I'd like to introduce my place of work. So I'm affiliated to the University of Pretoria, and the Cleft Clinic is an established clinic that has been established by Professor Kurt Butow in 1983. And we've recently celebrated 37 years of work with cleft lip and palate. Currently, we see approximately 110 new patients a year, which is nothing to rival the numbers that our Indian colleagues see. However, 10 new babies a month definitely puts a burden on any system. And a lot of literature has come out of this clinic, especially with regards to Pierre-Robin syndrome. And I will put the slide up at the end for the residents to take note of. So our clinic is a multidisciplinary clinic with the community nurses as a central hub. The aim is to give comprehensive care to all of our patients. And just a small note on our referral base. Most of our babies that are referred to the clinic are referred from general practitioners, medical doctors, and the second largest referral base is from the pediatricians. So we see patients of all ages, however, mostly newly born. It's not uncommon to see older patients at our clinic. So Pierre-Robin syndrome forms, or Pierre-Robin sequence forms part of the cleft lip and palate syndromes. It's been emphasized that this is a constellation of micrognathia, which results in the tongue falling back and causing airway compromises. A cleft palate is not a prerequisite, as these conditions may occur with a cleft and without a cleft. Syndromic association occurs in approximately 20% or less of these problems. So this diagram was shown before. Essentially, the small mandible fails to support the tongue forward, which results in prolapse and causes an airway compromise. So as mentioned before, the incidence of Pierre-Robin syndrome is approximately 1 in 8,500 to approximately 1 in 14,000 cases. And these cases, and the cleft palate association does not have to have a U-shaped configuration. In fact, the distribution between U and V-shaped is approximately 50%. I'd like to make mention of this classification that was described in 1994 by a group in Canada, where that stratifies the risk of mortality, where group 3 with respiratory distress has approximately a 41% mortality rate. So how does this syndrome or sequence develop? We're not pretty sure. However, the mechanical theory of mandibular hyperplasia as a result of hyperflexion seems to be the most plausible, although there are other theories which implicate abnormal development of the musculature that regulates swallowing and breathing, as well as the abnormalities within the brain structures that downregulates the swallowing reflexes. Am I audible?
Yes, sir, you're audible, sir.
Okay, thank you. So with regards to syndromic association, in 1978, Cohen published on approximately more than 20 varied syndromes that may be associated with Pierre-Robin. However, we know that Stichler and Wheeler-Cargill syndrome seems to be the most commonly occurring association. And it's important to be able to distinguish between syndromes and non-syndromic cases, because in syndromic cases, as our previous speaker alluded to, the problem is not so simply or not isolated to the hypopharyngeal area. It may be associated with skull-based abnormalities, with pharyngeal hypertonia, with nasal airway obstruction, as well as associated central nervous system abnormalities. So this is a typical presentation of how the babies present: small chins, difficult difficult breathing. So just to go back into the history, right? So Pierre Robin, as mentioned before, he was a French dermatologist that published approximately 17 papers on Pierre Robin. However, the first presentation that he published was made in 1923, and the second followed in 34. However, if you were to peruse the literature thoroughly, the published documentation of this problem featured initially in 1835 by von Siewald, and he presented on a child that presented with breathing problems, and the child did not have a cleft palate. And this was followed in 1846 by Fairbairn, who presented on a child that suffocated and died of asphyxia, and this child had a cleft palate association. So it seems more fair to give credit to these individuals. And in a paper, as I displayed earlier, in a paper that was published from our unit in the Annals of Maxillofacial Oral Surgery, we actually stratified or subclassified the Pierre Robin into a Siewald-Robin sequence and Fairbairn-Robin triad, where the Fairbairn-Robin is actually the condition that encompasses the cleft lip and palate. So as Professor Heinrich mentioned, that these have wide clefts and they may grow close with the aid of a orthodontic plate. But the big problem here is that the tongue may fall into the defect and cause airway compromise. So just a little bit on the epidemiology of Pierre Robin at our clinic. We've published in 2016 on 266 cases. However, the current numbers in excess of 292, close to 300. It's important to note that in this series that I'm presenting on, approximately 6% of Pierre Robin makes out of approximately 6% of our entire cleft population, of which 90% have cleft palate and 9% do not. The gender distribution is unremarkable. And for those of you that have been to South Africa, you would be aware that we have a vast population group of various ethnicities. At our clinic, approximately 75% of babies are white Caucasian, and this is closely followed by our Black population group. And 78% are isolated, 16 have syndromic association, of which Stickler syndrome seems to trump the lot, and followed by De Marque-van der Weyden syndrome. Of the patient population of a clinic, the group that are able to volunteer information on the amniotic fluid volume, we've noted oligohydramnios to be approximately 20% implicated, 20% involved in our cases. And this results in hyperflexion of the neck with a mechanical obstruction of the forward movement of the jaw. So catch-up growth, right? We know it's a common entity, and this is the basis of which tongue lip adhesion is based on for the mandible to grow forward. And in some cases, we get over-exuberant mandibular catch-up growth, as in this case, where this lady has developed into a class 3 deformity. What we've noted in our subset of patients is that the patients in the Siewald-Robin sequence group, the patients without cleft lip and palate, they do not have catch-up growth, as opposed to the patients with cleft palate. We have approximately a 30 to 35% catch-up group, implying that a third of our patients with Pierre Robin syndrome with cleft palate will have catch-up growth. And yeah, so our approach to patients with Pierre-Robin. It must be noted that we need to be cognizant of the fact that these kids could have laryngomalacia or tracheomalacia, as mentioned by Ms. Stevenson. And these children have a risk of failure to thrive purely because they cannot feed, because of difficulty feeding, and also because of the amount of energy expenditure they have to give into to feeding and the long extended times that they require to feed. So the feeding challenges that these kids encounter are poor feeding, longer feeding times. They may desaturate during feeding. They gag, they vomit, and they aspirate. And they may also have frequently recurrent bouts of pneumonia and gastroesophageal reflux disease. And this is also a reason why we struggle to feed these kids orally once the airway problem has been sorted out due to oral feeding aversion. So a thorough multidisciplinary workup is important, as mentioned by our previous speakers, that involves a number of specialties. And as I mentioned earlier, we need to distinguish whether there is a syndromic association. So there are many complex algorithms in the literature. However, I'd like to just keep it simple for this with this talk. So the basis would be to address the airway. And once that is sorted or managed, we need to address feeding. And they are interlinked, as since the child may not be able to feed, a child with a compromised airway may not be able to feed, and a child that doesn't feed may not be able to maintain adequately a patent airway due to lowered muscle tone. So the airway assessment is important, and we need to be able to distinguish between a stable airway and an unstable airway. These patients present with glossoptosis, they may have stridor, sternal retractions, and postural desaturations. And it's important to be able to perform bronchoscopies to identify or to exclude lower airway problems or occlusions, to maintain continuous airway saturations, and to perform polysomnography or sleep studies to distinguish between an obstructive cause or a central CNS cause of airway obstruction. In those cases that are stable, we may continue with side or prone positioning, continue and maintain. The aim would be to maintain normal and continuous saturation, to optimize feeds with the aim of approximately 20 to 30 gram weight increase per day. Proning helps by posturing the tongue and the mandible forward to alleviate the airway problem. But as Prof mentioned, we should be cognizant of sudden infant death syndrome. So in patients with unstable airways, what do we have in our armamentarium? We could consider nasopharyngeal airways, as mentioned by our ENT colleague, with or without supplemental oxygen, suction and drinking plates, and then our surgical interventions. So I tend to favor the use of nasopharyngeal airways, and as mentioned earlier, they can be used for a prolonged period of time. And this is our go-to therapy modality, the suction and drinking plate, which is essentially on the left, a HOTS plate with an extension posterior. Hello?
Please carry on, sir. Please carry on.
Okay. So it's essentially a HOTS plate with an extension posteriorly that aims to splint the tongue in a forward position. On the right is the pre-epiglottic baiting plate that Prof has mentioned. So we have huge successes in our cohort with the suction and drinking plate, with regards to both airway problems and feeding problems. I'd like to just allude to the surgical interventions that could be utilized. So the subperiosteal mouthflow release is aimed at releasing the attachments of the digastric in your junior glossal and junior hyoid muscle at the junior tubercle. And the aim would be to release that so that it causes posterior displacements of the attachment and allows the tongue to move forward. With regards to the tongue lip adhesion, this was initially or historically a modality that was aimed to reduce the usage of tracheostomies and the morbidity associated with it. And there is variable feeling in the literature with regards to its successes. In our unit, we tend to have approximately 70 to 80% success rate, and I'm a firm believer that it's very technique sensitive, and the success rate is linked to the technique that is used. And we often tend to do a glossopexia together with a tongue lip adhesion and a subperiosteal mouthflow release. And this seems to work very well. With regards to the candidates, the ideal candidate for a tongue lip adhesion, Gary Rogers published this in 2011, and he is from the Boston group. And this is the Guild score that actually gives you an indication of the success of a TLA. And in cases with 3 or more positive features for the above, there is a 5 times likelihood of failure for a TLA. So we should be cognizant of this classification system when considering to do a TLA. Again, this is a glossopexia together with a tongue lip adhesion. So the mandibular distraction osteogenesis is very popular. It's a very popular modality in the United States. However, I'm not a proponent of this technique in the early stages of management of PRS, simply because of the morbidity associated with the procedure. It requires a wide dissection. There's a risk of infection, as with all surgical procedures. However, there is a risk of neuropraxia to the facial nerve, injury to the tooth buds. So in our unit, we would essentially attempt the previously mentioned modalities and progress to mandibular distraction only if there were no other option. Essentially, the MDO addresses the problem of the hypoplasia of the mandible. But if we are able to maintain the airway with the other modalities that rely on muscle tone, we would opt for that first. With regards to mandibular distraction osteogenesis, as I explained, it may be the literature alludes to internal and external distraction techniques. We ordinarily favor the internal technique because it's a one-to-one vector distribution. There's less risk for external wound contaminants. However, it is a big procedure, and in general, distraction osteogenesis requires a second procedure for removal of the device, which is often a much bigger surgical procedure than the actual insertion of the device. This is just a kid that has had the distraction osteogenesis, and you can appreciate the advancement in the jaw length. What was the point of this? Okay, the point was to elaborate on the fact that the distraction osteogenesis actually addresses the problem by lengthening the mandible. However, the TLA actually addresses the problem by firstly allowing for the child to grow, to develop muscle tone, to allow the child to be fed and get stronger, to be able to maintain airway, and also it allows for catch-up growth to take over. So it's essentially a transient procedure which needs to be released at the time when the tooth buds or the teeth of the lower jaw begin to erupt. So tracheostomy is the way to go for patients with lower airway obstruction. However, most of the upper airway obstruction problems are meant to be dealt with trache-sparing procedures, as emphasized earlier, purely because trachecare is tracheostomy morbidity is so high, and the trachecare is such a high intensive requirement. We should obviously emphasize feeding as well, because if the child is able to feed, the child improves on muscle tone and certainly develops control of the airway. So we have different feeding positions that we could utilize. And as mentioned earlier, the suction and drinking plate plays an enormous role in our clinic with regards to feeding. And then we look at specialized bottles, and nasogastric feeds are a very good go-to during the interim period whilst we allow the child to develop airway control. And in those cases that are either syndromic or where there is a perception that there might be prolonged trachea or have prolonged developmental delays, gastrostomy should be considered. So the suction and drinking plate, as I mentioned before, it's a simple hot plate that's impressions taken in the mouth. This plate on the right hand side, which is actually an acrylic base, gets relined and placed into the mouth. Feeding bottles, we prefer soft bottles that are squeezable. It allows for a more constant stream and lessens the energy expenditure for suckling. As mentioned earlier, the Mandela bottles with the Haberman reservoirs of benefit in cleft patients. I personally prefer pigeon bottles, and the reason for the picture on the right, it's to emphasize that the flow of milk is important, because you don't really want a baby that's weak and low birth weight to have a lot of energy expenditure to suckle or to suck extensively. And then we're looking at nasogastric and your PEG tubing. So to summarize, Pierre-Robin syndrome or sequenced children have a life-threatening airway. They may be divided into SRS or FRT. Be cognizant of the fact that approximately 20% are syndromic, and take note that approximately 30% of the Fabian-Robin may have catch-up growth, and this is to emphasize that distraction to correct the jaw position may not be the most ideal modality to go to if the intention is to correct the mandibular position. Allow for normal growth. We would essentially consider correcting with distraction beyond the age of 2 years. So I've just mentioned the modalities. So this is just a case of mine that I've experienced in this year. The initial go-to was a plate. The child was too small and didn't tolerate the plate. So we progressed onto a nasopharyngeal airway. You can see that she presented with a persistent tachycardia and had a number of apnea attacks. We decided to go to theater and progressed to performing a tongue lip adhesion together with a glossopexy and a mouth flow release. And this is a week post-operatively. And this is the kid 2 weeks ago at 8 months of age. No extensive surgery was performed except soft tissue intervention. The child's growing, the child's maintaining airway on his own. It's a boy child maintaining airway on his own. And we've actually concluded all the intraoral cleft surgical procedures. This is a worthwhile read. The book published by Prof is a free download for those of you that are interested. And thank you from South Africa. And thank you for being given the opportunity to talk. Hello.
Thank you, Dr. Naidu. Thank you so much. Thank you so much, Dr. Naidu, and big thanks to all the speakers who contributed to this today's webinar. So I have arranged a small panel discussion. It will be about 20-25 minutes. I would be asking a few questions from my side with my own experience, and I would be also taking in a few questions which we have received from the YouTube and the Zoom platform. So to start with, just give me a minute, let me share my screen.
Dr. Naidu, yeah.
So, Abhilasha, can you see my screen?
No.
I can see it.
Now, yes, now we can see it.
Okay, here you go. So, as Dr. Bhandarkar had to excuse us because she had another meeting to attend. So let me go to Dr. Mane. I have a question, Dr. Mane, regarding what do you expect from a surgeon when you're trying to intubate or when we are trying to take these babies for surgery? What do you expect as a surgery colleague? Say for instance, one of us. What do you expect from us as to be as a part of the treatment during the intubation procedure or anesthesia procedure?
Yeah, one thing is this question was raised in one of our discussions before, that some of the procedures can be done under sedation. Okay, the thing is, see, the surgery is in the airway. In fact, okay, near the airway or whatever in the airway. So we are going to share the same field. Okay, so somehow we'll be losing control of the airway. Okay, so basically what I feel is it can be a minor procedure as well. As you told, it can be a minor procedure. The thing is, it can be managed maybe under sedation, but somehow I feel we need to have a control on the airway, and at least a nasopharyngeal airway has to be introduced in these kind of patients, and the respiration can be monitored at least.
Okay.
If not a nasotracheal intubation, at least a nasopharyngeal airway, which can help us to know the patient's respiration, which can help us to judge the patient's respiration.
Okay. Would you always suggest would you always have a ENT colleague as a standby for tracheostomy for all these patients?
I feel it goes by patient to patient, case to case.
Okay.
In my personal experience, there have been some instances wherein we ask for a standby ENT surgeon, but most of the cases we do go ahead with either fiber optic intubation. Most of the cases, many a times we do a normal, as I said, paraglossal technique of intubation.
Correct.
So in some cases we do ask for a ENT standby, which are difficult ones. Yeah.
Okay. The thing
I
is
don't know
that
about the other panelists. Let them speak about that.
correct. I'll just ask the same question again. Well, Dr. Hemfrisch, I just want to know that the conservative management is quite fascinating part of this, but unfortunately, that those plates are not available with us right now. But still, I would like to ask: is like how long these babies are? They stay with you in the hospital after the plate management when you insert the plate and you manage these babies?
You speak about these pre-epiglottic baton plates?
Correct, correct. Sir.
Yes. Okay. Well, usually 12 to 20 days, depending on the way the parents learn how to use these plates. Normally, it works well after this time. We have had some patients who had to be kept for 4 weeks, but usually the average is 12 to 20 days.
And these plates are inserted as early as possible?
Again, please,
these plates are inserted as early as possible, say in the first week of
oh
birth
yes, yes. We are usually called by the neonatology when they have a Robin child, and they ask us right away if they see a problem with the airway. They usually put a nasogastrial tube in first, but then they really call us right away and say, well, could you please do something about it? And normally, within the first week, we have an impression taken or now a scan made, and it takes a day or two to make the plate. And then we need one of those people of the neonatology to sedate the child, no anesthesia, but then perform the endoscopically assisted insertion of the plate. Yes, without the first 1 or 2 weeks.
And these plates are in situ till the time you repair the palate?
In situ until?
Until you go ahead and repair the palate?
Oh, yes. No. Normally it is good enough to have them for about 3 months, 3 to 4 months. And then they can be replaced by just a simple palatal plate to keep the tongue out of the cleft. Because, of course, it is more of an effort to keep this plate taped to the face. And usually after 3 months, the forward movement of the mandible is good enough, so the airway is sufficient.
Okay.
And usually we repair the palate at about 11 months of age.
11 months, yeah. And what kind of repair do you prefer, sir? Like, do you prefer intravelar viloplasty or furloughsplasty for these patients?
Never furlough, because I've not seen any advantage of the furlough viloplasty. We did our own examinations, and we didn't see any problem with the speech that could be made better by the furloughplasty. It's not the question of the length of the palate, but of the good intravelar viloplasty, of the very fine reconstruction of the velar muscles. And that is very important.
Hold on, sir.
That's good enough.
Yeah, another question to Kate. Kate, very well presented about the protocols you use in your setup, and it looks a fantastic place to work in. So, because you've already spoken everything which I wanted to ask you about, but one question which was which was like in my mind is, what is your decannulation protocol? How and when do you start decannulating these babies?
When do we start? What doing with these
It's
babies?
the question for Kate. Kate. The question is for Kate.
Oh, I'm sorry.
Thank you.
Okay, for
Thank
Kate,
you.
I'm so sorry.
That's okay.
No problem.
Maybe you can talk on tracheostomy decannulation. I suppose for those with the tracheostomy, you have it for the minimum amount of time needed. But when we do it, we anticipate that the child will need it for months to years. You know, you don't do a tracheostomy if you think it's only needed for weeks, because a neonate could stay intubated or on non-invasive ventilation for that time, if it's only a short period. So it's got to be months to years, but you want to be proactive and think about decannulating as soon as possible. And part of that is looking after them whilst they've got the tracheostomy, thinking about the tube size, putting on a tracheostomy valve as well, what might be called a speaking valve. That might help with the decannulation in the future. So you're always anticipating the decannulation. But basically, as when it's not needed anymore. So if it's not needed to cover any surgery, if it's not needed for airway access, so you have to have a child that in an elective and an emergency situation, their airway can be secured. If you think you've got a child who, say, if they had appendicitis and they needed intubation, if no one was going to be able to achieve that easily, they might need to keep the tracheostomy longer. So it would be a multidisciplinary approach and looking at polysomnography, checking in terms of obstructive and central pathology, that the child is ready. And then a decannulation protocol for us would be an in-hospital stay for usually about 5 days, downsizing the tracheostomy, capping it in the daytime, capping it in the nighttime if tolerated. And then if that is all satisfactory in terms of monitoring, then removing the tracheostomy, covering the stoma, and at least 1-2 days, making sure that they're stable day and night. But usually the challenge when they're capped in the night and daytime, you've got a little tube in the airway, so that's probably the greatest challenge to them. But we would always do an up-to-date airway endoscopy before decannulating, have up-to-date data as well about their polysomnography status, and make sure that they won't need it for airway access anytime soon.
So there must be a lot of emphasis on the nursing care or the nursing care from the nurses, and managing this tracheostomy must be really difficult part of managing these children, isn't it?
It is indeed, but I think we start from the very beginning. So even before the tracheostomy is performed, the parents are educated, the parents start to learn about tracheostomy care even before the procedure. So you're already planning for the home care. But we're in a very fortunate situation with tracheostomy specialist nurses, community nurses. We can ventilate children at home. We can look after children in the community with nasopharyngeal airways. And I know, I'm conscious that's not the situation everywhere.
Okay, hold on, Kate. There, I have a couple more questions for you. I'll come back once. Yeah. Okay, Dr. Kane, can you hear me well? Dr. Kane? Hello, is Dr. Kane available?
Nilesh, I'm here.
Yes, sir.
Yes, I'm here.
Hi, sir. The question to you, I would like to ask you is that how do you communicate with your neonatologist before taking the patient for surgery? What's your communication with them? Like, you know.
That is not her texting you right there after you said you delete her number.
Could all the participants mute themselves, please? Could everyone mute themselves? Abhilasha, can you mute everyone, please?
Nilesh, you are the host.
I can't see my screen, please. I can't see. Okay. Anyways. Yeah, Dr. Kane, can you go ahead and answer the
Dr.
question?
Ali Reza, can you please mute yourself? Ali sir?
Sir, your voice is breaking. Yes, sir.
Hello. There are lot of
Doctor,
sounds are there.
yeah, Dr. Ali Raza, can you mute yourself? Okay. Dr. Kane, can you press your space bar and just speak?
Yes.
Dr. Ali Raza?
Am I audible?
Dr. Kane now, yeah,
Hello.
it's, you can, yeah, Dr. Kane, yes. So,
See, actually, neonatologists, they are they take care of
sir, your voice is breaking very badly.
when patient born with the problem. Hello.
Yes,
Is it
now
clear
it's
now?
better.
Hello.
Now it's better. Yes, sir, yes, sir.
Okay.
Yes.
Okay, neonatologists, they take care of the patient when the patient born with this problem or the initial period of the menopause. So for the surgical management is concerned, first of management. Hello, because the trial of this after few months, you not actually actually in the neonatal period.
Sir, your voice is...
Hello.
Yes, sir. Yes, sir.
Hello.
Yes, sir.
So we discussed the case with the neonatologist that even we are planning for the dissection, but at that time also we achieved the good dissection and we were able to relieve the obstruction. Till that time they will require and their help will be required. So they will take care of the patient till the completion of the process.
And like, sir, how soon do you want to intervene? Like, say, if the child is born with this, and then you see saturation is low, child is failing to thrive. So, how soon would you like to take? Like first week, 10 days,
Normally,
or wait? Okay.
Yes. Normally, not in days. Normally, we have to evaluate. We have to examine the patient. The patient is allowed to get mature. The lungs are very much immature, and that time the anesthesia is also a problem. And second thing, if you are planning for the tongue lip adhesion, then it's okay. But for the distraction, you have to wait for the 4 months, 3 months, 4 months.
Okay. Dr. Naidu, can you hear me well?
Yes. Yes.
Okay, sir. So, like, you're talking about mild cases, you do conservative management. And I'm sure you're getting excellent results with mild cases managing with the nasopharyngeal airways. Just in case, the child does not respond, even the milder version, what's your first take? Like, what is your first surgical procedure in that case?
So nasopharyngeal airways are not our first line of management. Often the kids are born, we are notified of a child with a retrognatic mandible, with an airway problem, and the first modality that we would implement would be a simple suction and drinking plate with a palatal extension to displace the tongue slightly forward. Often, as I mentioned, this would improve airway and feeding, right? And in approximately 70 to 90% of our cases are relieved with this intervention. So it implies that our cases, those cases would be mild cases. For the cases that do not respond to the plating, they would progress to a tongue lip adhesion, glossopexia. And a very, very small amount of patients have had a mandibular distraction or a tracheostomy as a result of the failed TLA. So that's basically it. I don't think I showed my last slide. There was actually meant to be an algorithm that was published out of the Boston unit, Bonnie Padua's group, and they actually emphasize that you should consider less conservative to more invasive surgery, which would be tongue lip adhesion, mandibular distraction, osteogenesis, tracheostomy. And it was published last year. Oh, this year actually, 2020.
Okay. So could you share a few reasons why a tongue lip adhesion fails? Because it's such a simple procedure. There is ample blood supply in there. There is no reason to fail, but still fails. Why?
See, the thing is, the only reason I could think of is that if you're gonna suture a piece of tongue onto the lip's a mobile part, and so is the tongue, but the tongue bears a heavy weight. It's a muscle mass. In my unit, I would almost exclusively perform a tongue lip adhesion together with a glossopexia, meaning that we put a deep suture in the base of the tongue and fixate it to the mandible via a circummandibular suture, which is separate. It's a technique that was published by Douglas. And force the base of the tongue forward and then do the tongue lip adhesion procedure. And I've noted over the last few years that by adding the mouth flow release, it's a minor procedure, not much blood loss. You perform it under the same anesthesia. It makes a large difference to the outcome.
Thank you. So just hold on. Dr. Mane, we were just discussing over the call when we were talking about when we're discussing what to present. Like most of these cases, like the tongue lip adhesion, I do under LMA, and you said that the airway, we share the airway and the surgical procedure. But the trickiest part is for a procedure which lasts 5 to 10 minutes, maximum 20 minutes. Would you still like to traumatize the airway while trying to intubate? Would you?
Is this
for the anesthetist? For the anesthetist.
Okay.
Dr. Mane, please.
Yeah, that's what. Now, see, once you do any surgery near the airway, the anesthesiologist will lose the control. If any emergency comes up in between, it's very difficult to manage.
Absolutely, I agree.
Yeah, that's why I thought at least a nasopharyngeal airway through which we can provide oxygen.
Okay. Nilesh, could I just add to that?
Yeah.
Yeah. 1 second. He's just finishing his answer.
Okay, sure.
Yeah, LMA is there. LMA absolutely is a better has a better airway control than a nasopharyngeal airway. That is fine, but I don't know how far that is going to be of help as far as your surgery is concerned. It may come in your way. I'm not sure. As far as it depends on the surgeons, from surgeon to surgeon. Some of them say that LMA comes in their way. They prefer any tube through the nasal nasopharynx. That is fine for them. So it's just a matter of the surgeon's convenience, either LMA or nasopharyngeal airway to be in place. Yeah.
Dr. Hemfrich, do you do these procedures regularly?
Well, we have never used the tongue lip adhesion, and we have never used the mandibular distraction osteogenesis. And from what I know in Germany, the big cleft centers don't use these procedures neither. And I just wondered why Dr. Naidu is still not using the, you showed the baton plate. And do you think you still need tongue lip adhesion when you can use the baton plate? In my experience, we didn't need any of these other procedures.
See, there's the wonder of having a multidisciplinary approach and varied views from different parts of the world. How the same same issues can be managed with different techniques. Yes, Dr. Naidu, you're adding on to something to this.
Yeah, the thing is, I've learned over my short years of experience that any procedure that could bleed is a risk for an airway in a child. Yeah. There's an immense risk for laryngospasm in a normal kid, even if you perform a small procedure like a frenulectomy. Yeah. The trickle of blood goes down to the larynx, they spasm, and then it's. Can you imagine in a child it's already a difficult intubation? The anesthetist will sweat. I mean, you would automatically convert to a tracheostomy, which bears a higher mobility because it would be an emergency tracheostomy. In response to Prof's question to me, in South Africa, there's a big disparity between private healthcare and public healthcare.
Okay.
With regards to the funding and with regards to, so the private healthcare system is very much first world.
Okay.
Public.
Kate, would you like to weigh in on this about TLA, and do you have had any failures with TLA? I mean, because I have 50-50 success rate with TLA, doing the same procedure on every child, but still it just fails.
Question for me.
Exactly. Yes.
Sorry, thank you. So I'm afraid, I'm not an expert in tongue lipidation at all. That's not something that comes under ENT in my field of practice. But I would share the concern that even a minor procedure, you need to have the airway control. So you may end up with an anaesthetic that takes 4 times as long as the procedure itself, but you'll need that secure airway. When I come into the emergency airway access, the algorithm that was raised earlier mentioned the cricothyroidotomy. And I would just like to highlight that's not really recommended in under 5-year-old unless you have no other choice and you're trying to save the child's life and there's nothing else you can do. So in an emergency situation, I would not do an emergency cricothyroidotomy. I would do an emergency tracheostomy. However, for a non-ENT, for an anaesthetist, if you have no other option, then it is practical, it is understandable to do an emergency front of neck access through the cricothyroid membrane. But I would only use that for non-ENTs. If you've got an ENT on standby, they should be doing an emergency trachea. You should be able to do that as quickly, if not quicker.
What's the scenario with conservative management with plates in UK? Kate?
I think it's highly variable. I'd like to think that we had the good multidisciplinary teams to make the prostheses and what have you, but even in our system, I think that's lacking. And it's taken very much out of the hands of ENTs. So if there wasn't an airway problem, these children's, I wouldn't be seeing these children. They'd be totally looked after by the cleft team, which here is more plastic surgeons than maxillofacial. But that just shows the variation in practice between specialties internationally. So cleft here is part of plastics rather than maxillofacial, really.
Okay.
Nilesh?
And yes.
I have what to say and a question too.
Yes, please, sir. Please.
Yeah, this is regarding the airway again, coming back. I think no anesthesiologist will leave the airway unsecured and give it to a surgeon.
Absolutely.
Yeah.
Surgeons are deadly people, sir.
Yeah, and you said that you do under sedation.
Yes, sir.
How is your anesthetist coping with that?
Well, actually, the thing is, sir, we have been working together for the last 10-15 years. And he's kind of understood how we work together. Now, the thing is that we are still unsure every time we do this. That's why I brought up that question to the panel about, we do take care of with the nasopharyngeal airway, as you said. But still, an intubated child is always safer than any other child. So I was just trying to take the consensus as to how it is done across the world, whether it is done under sedation or under proper intubation. That's my concern.
Absolutely.
So, of course, having an intubated child, there is nothing better than that. Nothing safer than that for doing any kind of procedure in the mouth.
This issue is everywhere actually. The surgeon always says it's just a matter of 1 minute, 2 minutes surgery. Yeah. Why you want to take all the trouble of intubating and causing more trauma, maybe?
I know, sir. Sometimes we get overboard with this, but I'm sure I'll talk to my anesthetist and I'll tell him that nasopharyngeal airway is a must before we do anything else from next time onwards.
Even with that, there's a chance of aspiration too, as one of the colleagues said. Yeah.
Absolutely, yes, absolutely.
Okay,
sir, absolutely.
Fine.
Yes, sir. Last couple of questions to the panel's surgeons panel. like Dr. Naidu, have you had any complications with distractions? I mean, have you had? Do you have a lot of experience doing distractions?
So my experience would be on older kids, 2 years and older. All right.
Okay.
Look, we would only consider doing internal distraction and not external distraction. And complications that are common are inadequate osteotomies, device failure, sepsis because of injuring the tooth bud, and as I mentioned earlier, placing a distraction device is not the challenge; it's actually the removal thereof. And for that reason, I'm actually not a fan of distraction.
Dr. Kotra, are you around? Dr. Kotra Shetty, sir? Dr. Kotra Shetty, sir? Dr. Kane, have you encountered trying to do a distraction and placing a screw, if it's an internal distraction, placing a screw, or if it's an external distractor, passing the pin and the pin loosening and not gripping on the bone itself? Then what do you do in such cases?
Post-operative period, there are chances of the bleeding. That's the problem.
So we can't hear you actually.
Hello, hello.
Yes,
Hello.
yes,
Hello.
yes. We can hear you now.
Hello. Is it audible
Yes, we
now?
can hear.
Okay.
Yeah, yeah.
So in post-operative period, we encounter the problems like the pin loosening. So sometimes you have to repeat the procedure or try to tightening it in under local anesthesia, or you have to manage on the single pin. Normally, you put the two pin on both sides of the osteotomy, and screw loosening that also happens. So again, you have to repeat the procedure or manage with the single pin. That's the post-operative complication. Other thing is it's associated with the distraction is that we don't have any control on the posterior segment. So when you distract, the posterior segment goes back. So finally, whatever the anterior, the forward movement is desired, you don't get. That's the greatest disadvantage of the distraction. So one should have the control over the posterior segment also, which is very difficult. That's the one thing which I have observed.
Okay, sir. Why I ask this question is because whenever we do this neonatal distractions, every time we try to tighten the screw, the bone just shatters because it's a membranous bone. Just looking at solutions to it, or we try to pass, just try
Actually,
to
we
insert.
should use a very small. No, you should use a very small size of the screw. Ideally, I use the cranioplasty. They are very small
Correct.
screw, and they need not to do the drill level. They are the self taping screw. So
Okay.
over the plate, you can use the cranioplasty. They are very small and they not require the drilling.
Okay, sir. Dr. Kotra, sir, are you around? Gosla, sir, would you like to add something to this practical issues associated with?
Yeah, the major issue with the placement of the distractor is a screw or the pin. And
Correct,
from what I learned in a bit of, I never had this experience of putting the pin through and through the mandible from one side to other side. But I knew a colleague in Belgium, in Antwerp, who had some experience in putting the pin from one side of the mandible to the other side from the floor of the mouth. So that way he says that he could control the stability of the pin. But as Dr. Rakesh Kayan has mentioned, is the best is to use the cranioplasty screws, where we use, they're very small, tiny, and they're self-threading. The self-threading screws are much more stable in comparison to the tapped ones or drilling ones. but it's all 50-50 chance. It's always, in fact, I did around 6 pediatric distractions. All of them, matter of time, they within a matter of month or 2 months itself, hoping so that the bone consolidates. But before that itself, the pin and the screws became loose all the time.
Okay. So we have a question from Zoom platform. Just last few questions. This is to Dr. Hemfrich. How frequently the plate has to be renewed or remade, or as the child starts to grow?
We usually renew those plates between 4 to 6 weeks in this time, depending on the growth, which we notice. So usually about once a month.
Okay. So every time we have to make a new impression and make a plate, is it? Or we can reline the same plate?
No, we normally do another plate. We just take another impression and make another plate, because you cannot just add to these plates. The fit wouldn't be perfect again to the maxilla.
Okay. Kate, do you want to add something to the discussion?
Yes, I want to thank you again for the invitation. I'm sorry, I shall have to go in a second. I've got a
we are closing.
15-week.
We are closing now.
Yes, great. Okay. Well, I've
Abhilasha,
got a 15-week-old baby who has a feeding problem.
Okay. Take care then.
Yeah.
And
thank you for being with us. Thank you.
Thank you being with us. And we really appreciate you taking your time off from family and your work, and being a Sunday, it takes a lot. Then it's a common agenda to learn something from each other. Abhilasha, do you have any other questions from anywhere?
No questions.
Okay, sir, Gosla sir.
Yeah, I think we can close it, Nilesh. I should thank all the wonderful speakers. Yes. I would personally thank Professor Alexander Hemprich, Dr. Rakesh Kain, Dr. Mane, Dr. Sharon Naidu, for coming and joining us and really enlightening us with these wonderful lectures. Thank you very much, all of you.
Thank you very much for organizing all this, Gosla.
Thank you.
So we would also like to thank the organizing committee members, the organizing associations who have helped us to get through this. That is, of course, Dr. Gosla and his unit, AOMSI, Abhilasha and Dr. Shinoy with CIOMS, and Indian Association of Sleep Apnea Surgeons. And all of these people have really helped me through all of these associations have actively helped me through getting this webinar, especially blessings from Dr. Gosla and Dr. Kotra, and of course with a lot of help from Dr. Abhilasha. I thank you all for being there, and wish you all a safe stay during this pandemic. And see you very soon. And let us help these babies.
Thank you, Rakesh. See you soon.
Thank you, Dr. Rakesh.
Thank you, guys. Thank you.
Thank you
for the invitation.
Thank you all.
Thank you. Thank you, everybody who has participated.
Bye-bye. Dr. Naidu, please give my best regards to Dr. Buto. I've seen him 2 years ago here in Leipzig.
I will do that, Prof. I will keep off.
Thank you very much.
Bye-bye.
Thank you, Dr. Naidu.
Thank you,
Dr. Hemprich.
Yes, thank you. Bye-bye.
Bye.
Bye-bye. Nilesh,
yeah,
you need to disconnect YouTube first.